Okay, so we're going to start with psychiatry. Um, the versatility. The Spirit Himself testifies with our spirit that we are God's children. Now, if we are children, then we are heirs, heirs of God and co-heirs with Christ. If indeed we share in His sufferings, in order that we may also share in His glory. Romans 8:16-17. Okay. The first part of psychiatry is classical conditioning. Classical conditioning is a type of learning in which a natural response, like salivation, is elicited by a conditioned or learned stimulus, like a bell, that previously was presented in conjunction with an unconditioned stimulus, like food. Classical conditioning usually elicits involuntary responses. Pavlov's classical experiments with dogs, ringing the bell, provoked salivation. Okay, so now we're going to take a picture. Look at this. Take a look at this picture. Okay, so this is exactly what first aid was talking about. Um, so in the very first picture, we have a dog and we have food. So we have a dog looking at its food and the dog is salivating. Second picture, we have a dog looking at a bell, looking at a ringing bell, and there is no response. Notice the dog is salivating by looking at the food, but there is no salivation, hearing the bell, right? Third picture, the dog is looking at the food along with the bell. So he's looking at the food along with the ringing bell. This this picture is a picture. It's a key picture, right? So basically, the dog is salivating not by hearing the bell, but because of the food, right? This is the dog's natural response to salivate to the food. But along with the food, they're ringing a bell. So the dog salivates looking at the food and hearing the bell. Last picture. Now the dog only needs to hear the bell to salivate because the dog is thinking about food. He associates the bell with food, so he will salivate just by hearing the bell ring. And this is Pavlov's experiment. So we have this. What is the before conditioning? So this is what it looks like before conditioning, and this is what it looks like after conditioning. Okay, before conditioning. So what is the unconditioned response? Unconditioned response is the dog salivating, and then the unconditioned stimulus is the food. And then what is the conditioned stimulus? The conditioned stimulus is the bell. Okay, so conditioned stimulus is the bell, and the conditioned response is the salivation in response to the ringing bell. So here in this picture, the second picture, there is no response, so the bell will be neutral. The bell only becomes a conditioned stimulus once the dog starts salivating. You see this? Okay? And so the conditioned stimulus is the bell, the conditioned response is the salivation to the bell. Okay, next. And this is involuntary. Okay. Operant conditioning. Operant conditioning is a type of learning in which a particular action is elicited because it produces a punishment or reward. Operant conditioning is usually elicits a voluntary response. Okay, so operant conditioning is where a particular action, is done because that action will give you a punishment or a reward. Okay, now we're going to get into the three different types of operant conditioning. Number one, reinforcement. Number two, punishment. And then extinction. Okay, so reinforcement. Reinforcement is when the target behavior is followed by the desired reward or removal of the aversive stimulus. Okay, so here target behavior, which is a response, target behavior, which is the response, is followed by the desired reward. Okay, or removal of the aversive stimulus, and that would be negative reinforcement. Okay, so reinforcement, what you have to know is that in reinforcement, behavior is always going to be increased. In reinforcement, the behavior is always going to be increased, whether that is going to be negative or positive reinforcement. So, for an example, a kid. Okay, we're going to go through an example. A kid does homework because he wants a gift or candy, so the behavior is the response, and reward is the candy. So here, the kid does his homework because he knows he's going to get candy. So what is the behavior? The behavior is homework. There's an increase in homework. And then what is the reward? The reward is candy. And this is positive reinforcement. So that's what it means. Target behavior is followed by desired reward. Next, removal of aversive stimulus. Okay, so here this is an example of negative reinforcement where somebody does something so they can avoid something unpleasant. So an example would be example of negative reinforcement would be applying sunscreen so you don't get sunburned. Okay, so what is the behavior? You apply sunscreen. There's an increase in sunscreen use. Why? Because you don't want to get sunburned. Huh? Okay, so that's what that is. So you increase the behavior by removing the annoying thing. That is negative reinforcement. Yeah. Okay. So punishment. What is punishment? It's a repeated application of aversive stimulus or removal of desired reward to extinguish unwanted behavior. So a repeated application of aversive stimulus. Yeah, repeated application of aversive stimulus would be positive punishment. What is an example of that? I don't condone this, but spanking your kid. Spanking, like let's say your kid is stealing, and then you spank him. Here the action. Okay, so let's see. The punishment, like the action, his action, which would be stealing, would go down. And spanking, if you keep spanking your kid, he's not going to steal anymore. So spanking would be repeated application of the stimulus. And what happens to his behavior? He stops stealing. So that is an example of positive punishment, where like the parent keeps doing something so the kid's behavior decreases. An example that we gave was spanking him because he keeps stealing. Okay, and then removal of a desired reward to extinguish unwanted behavior. This is an example of negative punishment. So here you remove a reward, so there is a decrease in behavior. An example of this would be taking away an iPad from a kid to decrease screen time. Okay, so what is the um, what is the behavior? Decrease screen time, right? Because in punishment, behavior always decreases. What is the um, what is the desired? What's being removed? Removal of a desired reward. What is that? Taking away iPad, removing the iPad. Okay, so that's punishment. Extinction. Extinction is discontinuation. Um, yeah, discontinuation of reinforcement, which can be positive or negative, and this eventually eliminates behavior. Extinction can occur in operant or classic conditioning. Okay, so what this means is when positive or negative reinforcement is stopped, and this causes behavior to be eliminated. Yeah, when positive or negative reinforcement is stopped, and this causes behavior to be eliminated. For example, if a child throws a tantrum and gets attention, and parents consistently ignore the tantrum, the tantrums will eventually stop. Let me repeat that. Okay, so if a kid throws a tantrum and his parents always give him attention, what is that an example of? Okay, so what's happening here? The kid keeps throwing tantrums, right? So is his behavior increasing or decreasing? It's increasing because he keeps throwing tantrums. Now, because he knows that his dad is going to give him attention, right? So, um, the kid throws a tantrum because he wants a reward. And which one is that? That would be because the behavior goes up. We know it's reinforcement, and it's followed by a desired reward, right? It's followed by a desired reward. So that is positive reinforcement. Now, extinction means discontinuation of reinforcement. In this case, that we just gave, discontinuation of a positive reinforcement that eliminates the behavior. So let's say the kid throws tantrums, and he knows that his dad's because he knows his dad is going to give him attention, and eventually dad just stops paying attention. He stops paying attention, and then the kid will eventually stop. He will stop throwing tantrums because he knows there's no reward, there's no use for this anymore, right? So discontinuation of positive reinforcement eliminates the kid's tantrums, and this can happen in either operant or classical conditioning. Okay. Let's see. Okay, that's what that means. And now we have um, this positive reinforcement. See this. In positive reinforcement and negative reinforcement, there is an increase in behavior, right? There's an increase in behavior. Um, the difference is in positive reinforcement, you add a stimulus. Okay, you add a stimulus, and then in negative reinforcement, you remove the stimulus, right? You remove the stimulus. Okay, so that remember this. And then in punishment, the behavior always decreases. Okay, it always decreases. In the behavior always decreases in punishment. The difference is in positive punishment, you add a stimulus. Like the example we gave here was spanking the kid, because spanking would be the stimulus, and then decrease in stealing would be the behavior. In negative punishment, the behavior decreases because we're talking about punishment. The difference between positive punishment and negative punishment is in negative punishment you remove the stimulus. The example we gave here was taking away the iPad to decrease the screen time. So what is the behavior? Decrease screen time. And what is the stimulus being removed? The iPad. Okay, remember that. Oops. Now we're going to go into transference and countertransference. Okay, transference. Transference is when the patient projects feelings about formative or other important persons onto the doctor, like a psychiatrist is seen as a parent. So here, the patient projects his feelings on from his past onto the therapist or doctor. So transference is from what happens from the patient to the doctor. Uh, so here the example first it gives is a psychiatrist is seen as the parent. So a patient is talking to psychiatrist about his past trauma, his childhood trauma, and the psychiatrist gives him, counsels him and tells him that it wasn't his fault, and comforts him, and let's say um, the patient, he didn't have like a father figure, and because and things that he was supposed to uh, get from his dad he didn't get. The psychiatrist like guides him, um, but then the patient projects his feeling onto the psychiatrist, so he sees his dad in the psychiatrist, um, and this is transference, right? Now, yeah, that's transference. Countertransference. Countertransference is when the doctor projects feelings about formative or other important persons onto the patient. The example here is patient reminds physician of a younger sibling. Okay, so here the doctor projects past um, his past feelings onto the patient. So let's say the patient reminds him of his younger sister, and then he has memories of his younger sister when he sees the patient, right? So this is countertransference. Okay, ego defense. Thoughts and behaviors. Ego defenses are thoughts and behaviors which can be voluntary or involuntary, and they are used to resolve conflict and prevent undesirable feelings like anxiety and depression. Okay, this is actually like very interesting to learn about. Here we're talking about immature defenses. The first one is acting out. What acting out is when someone subconsciously um, is coping with stressors or emotional conflict using actions rather than reflections or feelings. An example is a patient skips therapy appointments after deep discomfort from dealing with his past. Okay, so this is subconsciously coping with stressors or emotional conflict using actions rather than reflections or feelings. So instead of talking it out, the patient uses his behavior to cope. Here, let's say a patient was in therapy, um, and the therapist tells him like there's ways to combat this, but makes the patient uncomfortable. And instead of telling his therapist that and working through his action, working through his feelings, he um, he replaces that with his action. So he skips therapy instead of talking to his therapist about it. Okay, so that's acting out. It's when you replace your behavior with your words. Okay, all right. Denial. Denial is when um, you're avoiding the awareness of a painful reality. Example is a patient with cancer plans a full-time work schedule despite being warned of significant fatigue during chemotherapy. Okay, so this patient has cancer. She's in denial. She no, the patient doctor tells her she's going to be very tired. She's going to experience fatigue, but then patient's like, nope, I don't have cancer. Instead of taking rest, she plans a full-time work schedule, despite knowing she's gonna need rest. She's in denial. That's number two. Number three, displacement. Displacement is redirection of emotions or impulses to a neutral person or object versus projection. We're going to get to projection in a bit, but displacement is a redirection of emotions or impulses to a neutral person. Okay. Example here is after being reprimanded by her principal, a frustrated teacher returns home and criticizes her husband's cooking instead of confronting the principal directly. So here is when you displace your feelings from one person onto another because you can't or don't want to confront your actual source of problems. So you pick on somebody else. So here, instead of talking to the principal, um, the teacher comes home and gets angry with her husband, gets her angry with her husband, knowing in reality she's actually angry with her work situation and at the principal. So that is displacement. Number four, disassociation. Disassociation is a temporary drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. Patient has incomplete or no memory of a traumatic event. Example is a victim of sexual abuse suddenly appears numb and detached when she is exposed to her abuser. Okay, so this is when you disassociate from reality because you don't want to deal with reality. So you forget. Like it's a temporary change, but you suddenly lose memory. Um, yeah, you lose memory or um, consciousness. Yeah, you lose memory or consciousness um, when you see the rapist. Yeah. Okay. So basically, you don't want to acknowledge that this has happened, so they appear indifferent, like it never happened. You dissociate from reality. Okay, that's dissociation. Okay, next we have fixation. Okay, now we're on fixation. Uh, fixation means fixation is a defense mechanism in which the person partially remains at a more childish level of development versus regression. We're going to get into regression in a bit. So, an example of this would be an example of fixation would be a surgeon throws a tantrum in the operating room because the last case ran very late. Okay, so fixation is involuntary, um, and it's when the person remains partially remains at a more childish level of development. So you wouldn't expect a surgeon to throw a tantrum, right? Especially in the operating room. Um, so that would be fixation. And fixation is more chronic and happens a lot. So we're going to quickly just get to regression so we can compare or contrast. Regression is an involuntary defense mechanism. Um, so they're both involuntary. So regression is an involuntary defense mechanism in which you turn back the maturational clock to behaviors previously demonstrated under stress versus fixation. Okay. So regression, you're turning back the maturational clock to behaviors previously demonstrated under stress. An example of this would be a previously toilet trained child begins bedwetting again following the birth of a sibling. Okay. So here you go back uh, to an earlier stage of life in which you it was common to do certain things. Like for a child, um, you know, it, it, it'd be common to wet the bed, right? It would be common to wet the bed. That's all part of the developmental stages. Um, Here, regression, you go back like an older child or older person goes back to that that stage of life, like a 3-year-old, where it was common to wet the bed, right? That's something a 3-year old would do normally, and an older person would go back to that stage of life previously demonstrated under stress. Okay, I think what they're trying to say is like it'll be normal for a child to wet the bed if they're stressed, right? And that's why it says involuntarily turning back the maturation clock to behaviors previously demonstrated under stress. Um, yeah. So it's fine for a kid, like a child, to wet the bed if they're scared or if they have a nightmare, right? So that's what that means. Versus fixation. You're turning back the clock, but it is more chronic and happens a lot, partially meaning at a more childish level of development. So this has nothing to do with um, going back to an earlier stage and doing something when they're stressed, right? Idealization. This is when you're expressing extremely positive. You're expressing extremely positive thoughts and of self and others while ignoring negative thoughts. An example of this would be a patient boasts about his doctor and his accomplishments while ignoring any flaws. This is like when you idealize somebody. Um, Expressing extremely positive thoughts of self and others while ignoring negative thoughts. So this can be about yourself also. You can idealize yourself. A patient boasts about his doctor and his accomplishments while ignoring any flaws. So this is like idealization is where somebody can do no wrong, whether that be somebody else that you admire or yourself. Let's make a note of this. And identification. Identification is a defense mechanism in which there is a largely unconscious assumption of the characteristics, qualities, or traits of another person or group. So, an example would be a resident starts putting his stethoscope in his pocket like his favorite attending instead of wearing it around his neck like before. Okay, so this resident identifies with his attendant, wants to be like him. So he puts um, his stethoscope the same way his attending puts it in his pocket. Okay, so this is unconscious. This is like unconscious thought that happens when you see somebody that you like, qualities, traits, characteristics, and you do the same thing. You identify with somebody else, so you start doing the same things as somebody else that you like. Just making a note. You start copying in identification. I wrote you identify with someone you like, so you start copying them. Next, intellectualization. Intellectualization is when you're using facts and logic to emotionally distance yourself from a stressful situation. Example here would be a patient diagnosed with cancer discusses the pathophysiology of the disease. Okay, so let's say somebody just got a trauma diagnosis, and instead of having, reactions that you deem normal, like fear, anxiety, they start talking about cancer, talking about the survival rates, um, the prognosis, um, who knows, pathophysiology, staging, all that stuff. They delve more into the knowledge side of it to get away from the fact that they're going to die because of cancer. Okay, isolation of effect. Isolation of effect means it's when you separate feelings from ideas and events. So here the example first aid gives is um, you're describing murder in graphic detail with no emotional response. So there was a home invasion, and somebody killed your husband. Like the robber killed your husband. The wife is explaining to the police exactly what happened without um, without without crying, without fear. She's describing exactly how he killed him. This would be isolation effect, where once somebody removes themselves, like the, I guess for lack of a better, the human part of themselves from the situation, and just starts spitting out graphic details, it's facts. Okay, so that's isolation of effect. So this is different from intellectualization. So isolation of effect is like like you don't show emotion. You're separating feelings, your own feelings, from the situation. Intellectualization is like facts and yeah, you're using facts to forget about the fact that you have cancer. It's different. I hope that makes sense. Intellectualization, yeah, you expect a patient that has cancer to be scared, asking questions, calling family in distress, but they are researching about the diagnosis and looking up, survival rates and how to get out of it, things like that. Isolation of effect is, it's been done, or whatever. It's like a murder has been done, or a rape has been done, and then they are explaining how it happened without showing any emotions. I mean, maybe they have like a stoic expression. I'm gonna make a note of this. Passive aggression. This is when somebody is demonstrating hostile feelings in a non-confrontational manner, showing indirect opposition. Example is a disgruntled employee is repeatedly late to work, but won't admit it is a way to get back at the manager. Okay, so somebody who's passive aggressive hates confrontation. They don't like confrontation, so they will um, physically do things that would make someone else mad. Like for example, like this, um, being late to work, knowing that it's going to make his boss angry, but he'll still do it anyway because he can't confront his boss. So he'll do something else that makes him mad. That he knows will make him mad. Projection, attributing an unacceptable internal impulse to an external source versus displacement. Attributing an unacceptable internal impulse to an external source. Okay. So a man who wants to cheat on his wife accuses his wife of being unfaithful. Okay, so projection is like you have your own problems that you know are not acceptable, and then you shift that onto somebody else. You shift those thoughts that are actually your own onto somebody else and accuse them of doing that same exact thing. So a man who is attracted to his coworker thinks his wife is cheating. So this is projection. Okay. It's when you shift your own thoughts onto somebody else to make yourself feel better. Rationalization. Asserting plausible explanations for events that actually occurred for other reasons, usually to avoid self-blame. Okay, so an example here is a man who was recently fired claims that the job was not important anyway. Okay, the rationalization for it's like sour grapes. You try to reach for that story with the fox. They try to reach for the grapes, and then he tries very hard, and then eventually says, "No, you know what? I want the grapes anyway because they're sour." So rationalization is very similar to that. It's like you think of explanations to make yourself feel better when you can't get something that you actually wanted. Um, like if you uh, steal something, like if you steal something from Walmart and say it's okay because Walmart is a $1 billion company, so they won't this piece of candy is not going to matter to them anyway. You're making an excuse in your head for that, for stealing, saying that Walmart is not going to miss this because they're a multi-billion-dollar company. Okay. All right. Okay. So reaction formation is when you replace a warded off idea or feeling with an emphasis on its opposite versus sublimation. An example is a stepmother treats a child she resents with excessive nurturing or overprotection. Okay, so reaction formation is like Cinderella's stepmom being nice to her, even though Cinderella's stepmom actually hates her. She's being overly nice to her because she knows that hating your stepdaughter is unacceptable and wrong, so she showers her with gifts instead, gifts and love, over her other two biological children. This would be an example of reaction formation. And the important thing is that like the stepmom hates her child, hates her stepchild, but she knows it's unacceptable, so she does more to overshadow that overshadow her hate. Okay, sublimation, we'll get to it. Regression. We did regression. Okay. Repression. This is when you are involuntarily withholding an idea or feeling from conscious awareness versus suppression. Okay, so you're withholding a feeling. Okay, a 20-year-old does not remember going to counseling during his parents' divorce 10 years earlier. You're withholding the idea from your mind so you don't have to deal with it. That's repression. Splitting. Believing that people are either all good or all bad at different times due to intolerance of ambiguity. Yeah, this is common in borderline personality disorder. A patient says that all nurses are cold and insensitive, but the doctor is warm and friendly. So splitting something is a defense mechanism that's seen in borderline personality disorder, where somebody is all good or all bad. There is no gray area. Um, Another example of this is like patient. You're treating a patient. Um, the doctor is late to come see is late to the see his patient who has borderline personality disorder, and she thinks that it's because, oh, I'm no longer important to him. Like let's say this was a doctor that was, you know, they had a very good doctor-patient relationship, and everything was good. But then one day the doctor got stuck in traffic, and he is now late to his appointment that he has with this person, with this girl, and um, the female patient says, you know what, I never liked him. He's not a good doctor. He never has time for me. This will be an example of splitting, because it just went from all good to all bad, no gray area. Okay, so next we have mature defense mechanism. A sublimation is when somebody replaces an unacceptable wish with a course of action that is similar to the wish, but socially acceptable versus reaction formation. Okay, so example is a teenager's aggression toward his parents because of their high expectations is channeled into excelling in sports. So sublimation is replacing an unacceptable wish with a course of action that is similar to the wish that's socially acceptable. Teenagers' aggression toward his parents because of their high expectations is channeled into excelling in sports. Okay, so sublimation is when you take something that's unacceptable and then make it into something that's socially acceptable. Like let's say, like if somebody is mad in this example, a teenager is very mad at his parents because he cannot meet their high expectations. But instead of going and attacking his parents, he turns all that energy and aggression into becoming an excellent sportsman. So this is socially acceptable, right? Another example of sublimation is like somebody that was bullied in school. Instead of hitting his bullies, he becomes a wrestler, and then he took his childhood trauma and turned it into an adult sport that is socially acceptable, right? So that is an example of sublimation. Altruism is when you're alleviating negative feelings by unsolicited generosity, which provides gratification versus reaction formation. Okay. Example of this would be a mafia boss makes a large donation to charity. Okay, so altruism, alleviating negative feelings with unparalleled generosity. Okay, so you do something that's completely out of proportion to your job or your way of life because you feel bad about what you're doing. Here, example is mafia boss makes a huge donation to charity. So this is done to feel better about oneself and be less anxious and guilty. Um, Another example would be a billionaire donates money to feel less guilty about being a billionaire. Okay, so this is altruism. Reaction formation is different. Reaction formation is you secretly hate someone or something, but you overly show affection and love so that no one knows that you hate that person, right? Altruism is done to make some, the person who is giving, like here the mafia boss, to feel less anxious and guilty about being a mafia boss. Okay, suppression. Intentionally withholding an idea of feeling from conscious awareness versus repression, and it's temporary. So here you are actually, you know that you're withholding an idea um, from the situation. So here is an example: an athlete focuses on other tasks to prevent worrying about an important upcoming match. So this is like when somebody compartmentalizes. There was an example in private practice where I think her name is Amelia. She actually she was a top neurosurgeon, right? But her baby was born with anencephaly. Well, baby would be born with anencephaly. She was like 8 or 9 months pregnant, and there was like her coworker who came up to her and said, "Hey, I don't think you should." She's got the diagnosis, and she was heartbroken, and she just came up. And like a coworker came up to her and said, "Hey, I don't think you should be operating." You know, I can't remember the case, but maybe it was like a pregnant woman. I don't remember. And she's like, "You know what? I cannot do my job if I couldn't compartmentalize. I'm forgetting about my baby right now, so I can save somebody else's baby." So, this is an example of suppression. She is withholding her own trauma, so she can help somebody else. Okay, so humor. Next one. This is lightheartedly expressing uncomfortable feelings to shift the internal focus away from the distress. Example would be a nervous medical student jokes about the boards. Yeah, so lightheartedly expressing uncomfortable feelings to shift. Okay, so yeah, so you joke about your problem, so you don't have to think about it. Yes. Next. Infant deprivation effect. Long-term deprivation of affection results in failure to thrive, poor language and socialization skills, lack of basic trust, reactive attachment disorder. Here, the infant is withdrawn, unresponsive to comfort. The next one would be disinhibited social engagement. The child indiscriminately attaches to strangers over their own caretaker. And deprivation for more than 6 months can lead to irreversible changes in the baby. Severe deprivation can result in infant death. Okay, so we this is effects if you neglect your kid: failure to thrive and poor socialization skills. The kid ends up not trusting anybody, and they can get two disorders: reactive attachment disorder, where the kid is withdrawn, not responsive to comfort, and disinhibited social engagement, where the kid attaches to strangers rather than their own caretaker, which is the opposite of what you expect, right? So that is a sign of infant emotional neglect. So there's one that we forgot in defense mechanism, that was undoing. Undoing defense mechanism is neither a mature or immature defense mechanism. You're trying to undo a situation after it happened. Example here would be a wife gets into a fight with the husband and yells at him severely, and that comes back to make this and comes back to make things better. Um, and she speaks very sweetly to him, but the damage has already been done in the undoing defense mechanism. This is different from reaction formation because the person doesn't know you hate them. So remember that undoing versus reaction formation. Okay, here child abuse. Okay, so the science is fractures, bruises, or burns, injuries often in different stages of healing or in patterns resembling pos- possible implements of injury includes abusive head trauma like shaken baby syndrome characterized by subdural hematoma or retinal hemorrhages. Caregivers may delay seeking medical attention for the child or provide explanations inconsistent with the child's development stage or pattern of injury. Epidemiology: 40% of deaths related to child abuse or neglect occur in children less than a year old. Okay, so here we have the signs of physical abuse: fractures, bruises, or burns, and the injuries are in different stages of healing, which means the kid has been repeatedly abused, and they have old scars and newer scars. Um, that is a sign of physical abuse in a kid. Head trauma, shaky baby syndrome. I'll show you a picture. Um, shaky baby syndrome. So this is shaken baby syndrome. See, so the baby's head is shaking back and forth because somebody violently shakes the baby, and the kid's head is heavy, and the neck muscles are not properly formed, so the head um, is bobbing back and forth, and that causes the brain like rupture. It causes rupture of the veins. One sec. Yeah, it causes the rupture of the brain. Okay, so you get some subdural hematoma, and you get brain swelling and retinal hemorrhages. Okay, because the brain is being um, like slapped against the skull. How's how I think of it. Is how I think about it. And this causes bleeding in the brain, and the brain swells, and you get and the retina. You get bleeding into the retina. So let me show you subdural hematoma. So this is a subdural hematoma. Um, sub looks like a banana. So say this pediatric abuse of head trauma. See that? It looks like a banana right here. This white part is all blood that's bleeding into the brain. Okay, so yeah, that's seen in shaken baby syndrome. So subdural hematoma. Let's look. Subdural hematoma is right here. See how it's like? It looks like a banana. So how I remember is that um, sub. It has the word B in it, so that's why I remember that. So in subdural hematoma, let's see, should we just subdural hematoma? So in subdural hematoma, this is the rupture of bridging veins, crescent shaped. Okay, bridging veins. Okay, just remember that. Okay, so subdural hematoma seen in child abuse. So subdural hematoma is a rupture of the bridging veins. Can be acute, traumatic high energy impact, like in shaken baby syndrome. It causes a hyperdensity on a CT scan, as you can see right here, this white, right? Or chronic, um, which is associated with mild trauma, cerebral atrophy, elderly, alcoholism, in which you see hypodense on CT. Also seen in shaken baby syndrome. Predisposing factors is brain atrophy and trauma. It's a crescent-shaped hemorrhage. Red arrows in figure C, right here, can cause midline shift. So the middle, like the middle of the brain, it becomes shifted. See, yellow arrow, instead of being right here, it's shifted over to the left. Can cause midline shift, yeah. Findings of acute or chronic hemorrhage, blue arrows in D. Okay, so blue arrows in D. So what do we say the hyperdensity was? Hyperdense on CT. It's this right here. Let's look. I believe hyperdense is this right here. This white part. And hypodense would be this, right? Hypodense. Okay, so um, crescent-shaped hemorrhage seen in C. Uh, yeah, seen in C and D that crosses suture lines. So remember, the subdural hematoma crosses the suture lines. Um, what are suture lines? Suture lines are this. Suture lines are sutures. The fibrous, immovable joints where the bones of the skull meet, allowing for skull growth. So So basically, this right here, the frontal bone, this would be a frontal suture, and coronal suture would be right here, frontal bone. So, so basically, what they're saying is, see these sutures? These are all like divisions of the skull. how the skull is divided: frontal, parietal, occipital, temporal. So they're divided by sutures. And what they're saying is that in subdural hematoma actually crosses the suture lines. Like the bleeding crosses the suture lines, whereas the epidural hematoma does not cross suture lines. See this? Epidural hematoma does not cross suture lines. In subdural, it always crosses the suture lines. Okay, so yeah. Now, as we were talking about um, acute or chronic, in acute we have hyperdense. Acute we have hyperdense region on the brain. Let's see. Okay. Hyperdense would be this white part. This is an acute trauma. This is an acute trauma right here. 1, 2, 3. Right. So in shaken baby syndrome, it would be acute. So you'd see white patches in the CT on the CT scan. Okay. So right here, see this? This is an acute um, trauma right here. Okay, and even on this one can cause midline shift. In this figure, you see it's white here. That means that it's acute. The trauma is acute right here on this side. And right here, this is hypodense. Hypodense is associated with chronic condition, um, mild trauma, cerebral atrophy, and in the elderly, alcoholism. So alcoholism is a chronic condition, right? So see this. If you take a CT of the brain, you can sometimes you can see the hypodensity right here, the darker spot. Okay. So if you just wanna see, I'll show you hypodense on CT. See this chronic hypodense hematoma, acute hyperdense hematoma right here, this white spot. Okay, remember that. Okay, and we're back. Now we're back to psychiatry. Okay, so shaken baby syndrome. We know that if you see a subdural hematoma, and subdural hematoma looks like a banana on the CT scan. Retinal hemorrhages. What are retinal hemorrhages? Here, retinal hemorrhage caused by the brain shaking back and forth in shaken baby syndrome. Okay. All right. So next we have caregivers may delay seeking medical attention for the child or provide explanations inconsistent with the child's developmental stage or pattern of injury, because so they won't bring the kid in because they don't want to get caught. Okay, next, sexual abuse. Sexually transmitted diseases, urinary tract infections, and genital, anal, and oral trauma are all signs of sexual abuse in a child. Most often, there are no physical signs. Sexual abuse should not be excluded from a differential diagnosis in the absence of a physical trauma. Children often exhibit sexual knowledge or behavior incongruent with their age. Okay, so in sexual abuse, most often there aren't physical signs. Um, Sexual abuse should not be off the list from a differential diagnosis, even if there's no physical trauma. You shouldn't rule uh, sexual abuse off the list if you don't see any physical harm. Um, it may or may not be present, the physical signs. Most often it's not, but you shouldn't rule it out if you don't see any physical trauma. So you should still consider sexual abuse in a child even if there aren't any physical signs. And children often exhibit sexual knowledge or behavior incongruent with their age. So children will know more about sex than they should. They shouldn't. Yeah. So like a 6-year-old know way too much for that. It'll be incongruent with what they should know. Children should know anything about sex, right? Like children. I feel like a 13-year-old, 14-year-old would know certain things, but like if 6-year-old were to know what like a teenager would know, that's alarming. Okay, so emotional abuse. Babies or young children may lack a bond with the caregiver, but are overly affectionate with less familiar adults. This is a sign of okay. This is a sign of emotional abuse. Babies or young children may lack a bond with a caregiver, but are overly affectionate with less familiar adults. They may be aggressive toward children and animals, or usually unusually anxious. Older children are often emotionally labile and prone to angry outbursts. They may distance themselves from caregivers and other children. They can experience vague somatic symptoms for which a medical cause cannot be found. Okay, emotional abuse. Babies or young children may not show um, much much of a bond to their moms, like like who is most often the primary caregiver, but they can be overly affectionate to strangers. um, that is a sign of emotional abuse, right? This goes back to this. See this: disinhibited social engagement. A child indiscriminately attaches to strangers. So basically, if you deprive a kid of affection, that's emotional neglect. They can get disinhibited social engagement issue. So they'll latch on to strangers over the primary caregiver, which is most likely the mother. Right? Ooh, okay. The kids may be aggressive toward children and animals, or very anxious. Older children are often emotionally labile, so which means they go through a range of emotions from angry to sad, to anxious, to happy, to angry. They exhibit a wide range of emotions. Um, and are prone to angry outbursts. The children may distance themselves from caregivers and other children. They can experience vague somatic symptoms for which a medical cause cannot be found. Okay, so basically, they can come with physical symptoms for which a medical there is not a medical reason. Okay, so they're basically their emotional trauma manifested as physical symptoms, and they're having physical symptoms because of the emotional neglect. Epidemiology, we covered this for um, physical abuse. 40% of deaths related to child abuse or neglect occur in children less than 1 year old. For sexual abuse, the peak incidence for sexual abuse is at 9 to 12 years old, and the for emotional abuse, 80% of young adult victims of child emotional abuse meet the criteria for one or more psychiatric illnesses by age 21. So, majority of children who are emotionally abused have one or more psychiatric illnesses by the age of 21. Okay. Child neglect. Failure to provide a child with adequate food, shelter, supervision, education, and/or affection is classified as child neglect. Most common form of child neglect is the most common form of child maltreatment. Signs: poor hygiene, malnutrition, withdrawal, impaired social and emotional development, and failure to thrive. As with child abuse, suspected child neglect must be reported to local child protective services. Okay. Vulnerable child syndrome, which is parents perceive the child as especially susceptible to illness or injury versus factitious disorder imposed on another. Usually allows a serious illness or life-threatening event can result in missed school or overuse of medical services. So here the parents believe that their child is actually very sick and they overburden the medical medical system to get the best treatment for their child who they believe is sick, and they won't send them to school thinking that they may get hurt at school. But this is a issue with the parents. Um, they're actually concerned for the well-being of their kid. Factitious disorder, but the problem is that it's to an unnatural extent. Factitious disorder by proxy is like somebody, like the mom or caregiver, is making the child sick for gain, maybe sympathy, um, financial gain, anything. Like it could, she could, for mainly it's for like sympathy from other people. Okay. Okay, so I want to correct myself. Vulnerable child syndrome is like, yeah, when the parents are overly concerned about their child due to an abnormal extent that they overused medical services that are not necessary, and the kid, they don't send the kid to school because they're scared that something might happen to the kid at school. Um, Now, versus this is different from factitious disorder by proxy. Usually, when the mom or the caretaker makes the child sick, or they can make their elderly patient sick, like the elderly mom or dad sick, for sympathy from other people. Factitious disorder is almost never for financial gain. That would be malingering. We're gonna get to that. So before I said factitious disorder could be for financial gain. It's usually never for financial gain. It's usually for empathy and to get medical attention from other people. Oh, you are caring for your sick child. And they get a lot of emotional gain from this. And this is actually child abuse. Like factitious disorder by proxy is definitely abuse. We're gonna get to that. Okay. All right. So next. Okay. So childhood and early onset disorders. We're gonna talk about attention deficit hyperactive disorder, otherwise known as ADHD. ADHD often occurs before the age of 12. You have 6 or more months of limited attention span and or poor impulse control. ADHD is characterized by hyperactivity, impulsivity, and or inattention in two or more settings. For example, the kid um, is hyperactive, impulsive, loses things, cannot pay attention in two or more settings, like at their house, school, church, um, like after school activities. If you notice, like the kid is always losing, the teacher complains of him losing homework constantly, and at home you notice the kid is always disruptive, and he loses things. He loses his glasses. So that is that is a similarity. He loses things both at school and at home, right? So you had to consider ADHD, and this must be going on for 6 or more months. Um, Kids with ADHD usually have normal intelligence, but commonly coexists with difficulties in school due to inattention. Often persist into childhood. So ADHD often persists into adulthood. ADHD commonly coexists with oppositional defiant disorder. We're gonna get to that. Treatment is stimulants like methylphenidate with or without behavioral therapy. Alternatives to methylphenidate include atomoxetine, guanfacine, and clonidine. Okay. Autism spectrum disorder okay, so it's an onset in early childhood. There is social and communication deficits and repetitive ritualized behaviors, restricted interests. um, Autism may be accompanied by intellectual disability and or above average abilities in specific skills like music or mathematics. Autism is more common in boys. Autism is associated with increased head or brain size. So autism, they have social issues. They can't communicate properly. They can't read the room properly. They have ritualized behaviors. They have very routine schedules. They like routine and the sameness um, in everything. You They have ringing, like you can. They have something known as stemming, which is like flapping of the hands. Um, is known as ringing of the hands, which is also like, I'll show you a picture. It makes it easier. Ringing. So it's a way to self-regulate emotion, sensory input, and deal with overwhelming situations. Um, I don't know if I can show a video, but it's stemming with the hands. It's like hand flapping. Let's see. See, like the hands, I'm often moving like this. I don't remember what that was. Uh, Twisting and rubbing one's hands together, a sign of nervousness. Yeah, and then autism, that's there, and also there's flapping of the hands. And they do this. Autistic children do this so they can self-soothe. Alright. Um, they also have restricted interests. You know, they're not interested in a wide variety of things that children normally are interested in. Maybe like obsessed. They're obsessed with the moon, or they're obsessed with trucks, or cars, or dinosaurs. Okay, so uh, and so they may be gifted in one area, um, like music or mathematics. These are known as savants. It is more common. Autism is more common in boys, and they usually have a larger head or brain size. Conduct disorder. This is repetitive, pervasive behavior violating social norms or the basic rights of others, like aggression towards people and animals, destruction of property, and theft. After age 18, conduct disorder is known as antisocial personality disorder. The treatment is by psychotherapy, for example, cognitive behavioral therapy. Okay, so conduct disorder is like, how I think about it is like baby. baby antisocial personality disorder. Before the age of 18, that's like antisocial personality disorder, in other words, is known as psychopathy. Before age 18, it is known as these individuals. They exhibit all the signs of antisocial personality disorder, but you cannot be diagnosed with the personality disorder until after age 18. So before age 18, um, even if they have the symptoms of antisocial personality disorder, it is known as conduct disorder. And so this is like, just no regard for other people, their properties, property, their things, even animals. Animal abuse is a sign of conduct disorder, um, even in the early ages. Was watching a documentary about this one guy. His name is Jamie Osuna, right? And this guy, okay, I believe it's Osuna. Osuna. Yeah, this guy. So he had like, even when I was watching a documentary about him, I I was very I I was seeing that he had all the signs of um, antisocial personality disorder. Like, it was so clear, but then I don't know how it missed, and then it resulted in in him killing people. He he could have been helped or treated as a kid. There was like signs, like he's been on record saying he used to microwave his house cat, which is, I can't even imagine someone saying that and thinking that's acceptable to say or do. So yeah, and he went to prison later on in life for something else, and then he ended up killing his cellmate in prison. So you know, it's actually very sad when you think about, when you associate things that you're actually studying to real life scenarios, like in this case. Okay. Next, we have disruptive mood regulation disorder. This happens before the age of onset is before the age of 10. This is a severe recurrent temper outburst out of proportion to the situation. The child is constantly angry and irritable between outbursts. The treatment is cognitive behavioral therapy and stimulants and antipsychotics. So in DM, I abbreviated this DMDD, the disease. So basically, it happens before 10, and they're the kids are very, very angry, out of proportion to whatever they're angry about. It is an abnormal, exaggerated reaction to whatever they are angry about, and they're irritable. You have to calm the kids down using therapy, and other drugs would be stimulants and antipsychotics. Intellectual disability. This is a global cognitive deficit versus a specific learning disorder that affects reasoning, memory, abstract thinking, judgment, learning, and language. Adaptive functioning is impaired, leading to major difficulties with education, employment, and communication, socialization, and independence. Treatment is psychotherapy, occupational therapy, and special education. So here, global cognitive deficits means they're affected around, like all around the in all categories of life, um, even in reasoning, memory, abstract thinking, which abstract thinking is ability to understand idioms, metaphors. So somebody with intellectual disability, if we told them it's raining cats and dogs, like a 20-year-old with the intellectual disability, if we tell him it's raining cats and dogs, he might think that there's actually cats and dogs falling out of the sky. Whereas if we told somebody that was of average average intelligence and didn't have a disability, intellectual disability, that it was raining cats and dogs, he would understand to take an umbrella because it's raining. It's he what is understood. What he understood was, it's raining heavily outside. So that is abstract thinking. So people with intellectual disability actually, they don't have abstract thinking. Um, the judgment is also impaired. Adaptive functioning is impaired. What is adaptive functioning? Adaptive functioning is ability to perform daily tasks. If you're independent, um, it relates to hygiene. So yeah, and you know people with this, they have disability. They have issues with education, being gainfully employed, communication, and even in their interpersonal relationships, they also suffer. Um, you know, and they need in school they need special education, occupational therapy, and psychotherapy. Okay, now we have oppositional defiant disorder. This is an enduring pattern of angry and irritability with argumentative, vindictive, and defiant behavior towards authority figures. Treatment is psychotherapy. So, oppositional defiant disorder. Okay, enduring pattern of angry and irritability with argumentative, vindictive, and defiant behavior towards authority figures. So they have a problem with authority figures. Oppositional defiant disorder. Okay, let's look. And oppositional defiant disorder commonly coexists with attention deficit hyperactive disorder. Remember we talked about this? That's what this is. So basically, they have issues with authority figures. Okay, so yep. Treatment is psychotherapy. Okay, selective mutism. Um, Onset is before age 5. Anxiety disorder lasting 1 or more months, involving refraining from speech in certain situations, despite speaking in other, usually more comfortable situations. Development, like speech and language, are not impaired. Um, Selective mutism interferes with social, academic, and occupational tasks. Selective mutism commonly coexists with social anxiety disorder. Treatment is behavioral, family, and play therapy. You can also give SSRIs, which are selective serotonin reuptake inhibitors, to increase the serotonin in the brain. Okay, so selective mutism happens before age 5. So this what this means is, um, anxiety disorder anxiety disorder lasting 1 or more months, involving refraining from speech in certain situations. So these individuals, they generally talk at home with a comfortable with their siblings, but if they are nervous or scared, they won't speak at school. They won't say much at school because they are, um, even though they have no problems physically speaking, they won't say because they have social anxiety. Yeah, and this can be treated with play therapy, family um, therapy, and behavior therapy. Pretty sure I had this as a kid. Okay, so let's see. Okay, take a break. So now we're gonna talk about separation anxiety disorder. This is an overwhelming fear of separation from home or attachment figures, like your mom or your dad, lasting 4 or more weeks. Separation anxiety disorder can be normal behavior up to age 3 to 4, and separation anxiety disorder may lead to fictitious physical complaints to avoid school. For example, the kid may complain of a tummy ache so he can go home early, and the tummy ache goes away after he gets home. Treatment is by cognitive behavioral therapy, play therapy, and family therapy. Okay. Okay. So now we have specific learning disorder. Onset is during school age years. And this is an inability to acquire or use information from a specific subject like math, reading, or writing. Near age expected proficiency for 6 or more months, despite focused intervention. General functioning and intelligence are normal versus intellectual disability. So in intellectual disability, there's a global deficit. It's all over. It's around the globe. They have issues with almost every aspect of life. But this specific learning disability is an issue with a certain subject, despite giving tuition, private tutoring, um, you know, making them read about that one subject. They still have issues with learning that one subject. Treatment is academic support, counseling, and extracurricular activities. Can I make a note of this? Okay, so now we have Tourette's. Tourette syndrome occurs before the age of 18. There is a sudden, recurrent, non-rhythmic, stereotype motor and vocal tic that persists for more than 1 year. You see coprolalia, which is involuntary obscene speech found in some patients associated with OCD and ADHD. Treatment is through psychoeducation and behavioral therapy for intractable and distressing tics, high potency antipsychotics. Give haloperidol and fluphenazine, uh, tetrabenazine, alpha 2 agonists like guanfacine, clonidine, or atypical antipsychotics. So Tourette syndrome typically happens before the age of 18. It's a sudden, recurrent uh, tic. It can be motor or vocal that persists for more than 1 year. You see coprolalia, which is involuntarily obscene speech found in some patients. So coprolalia is this. Coprolalia is an utterance of obscene or socially inappropriate words or phrases. They can't help it. So some examples would be curse words, some with sexual connotations. Um, so they may be speaking, but then randomly um, they'll get outbursts of curse words or sexual connotations between their sentences, and this is completely involuntary. Um, they often speak louder than the other. They speak louder in a louder voice when they're having these outbursts. Okay, so that is a sign of Tourette's. Okay, coprolalia. Tourette syndrome is associated with OCD and ADHD. Treatment is psychoeducation, behavioral therapy. For very distressing tics, give antipsychotics like haloperidol, fluphenazine, and tetrabenazine alpha 2 agonists like guanfacine and clonidine, or atypical antipsychotics. So, orientation means a patient's ability to know the date and time, where they are, and who they are, order of loss, time, place, person. Common causes of loss of orientation is alcohol, drugs, fluid and electrolyte imbalance, head trauma, hypoglycemia, infection, nutritional deficiency, and hypoxia. So, what this means is normally we're oriented to um, time, place, and person. um, we know where we are, we know what time it is, um, and we know who we are. So basically, what happens in orientation, um, they lose that ability to know time, place, and person. And the way that it's normally lost, they lose sense of time first, then they lose sense of place, then they last to go, last uh, thing that they uh, that's that their mind lets go, that they'll forget, is who they are. um, so time is the first thing to go. Okay, order, time is the first thing to go, place is the second thing to go. They want to know where they are, and then they want to know who they are. Common causes of loss of orientation: alcohol, right, drugs, and fluid and electrolyte imbalances, head trauma, hypoglycemia, infection, nutritional deficiencies, and hypoxia. And that is, we're done with childhood and early onset disorders. Okay, next we have amnesias. Okay, okay, so amnesias. Retrograde amnesia is the inability to remember things that occurred before a CNS insult. Anterograde amnesia is an ability to remember things that occurred after a CNS insult. There is a decreased acquisition of new memory. Korsakoff syndrome is amnesia, where anterograde amnesia is greater than retrograde amnesia, and disorientation is caused by vitamin B1 deficiency, and disorientation is caused by vitamin B1 deficiency. Korsakoff syndrome is associated with the disruption and destruction of the limbic system, especially mammillary bodies and anterior thalamus. Korsakoff syndrome is seen in alcoholics as a late neuropsychiatric manifestation of Wernicke encephalopathy. Confabulations are characteristic of Korsakoff syndrome. So, retrograde amnesia. You can't remember things that happened before the head injury. That is retrograde amnesia. In anterograde amnesia, you can't remember things that happened after the head injury. So there is a decreased acquisition of new memory, which means you can't learn or retain new information, and you can't form new memories. So patients will have trouble remembering recent events, conversations, or new facts. And that's an anterograde amnesia, which is you can't remember things after the injury. So A for after. Okay, Korsakoff syndrome. This is amnesia and disorientation caused by B1 deficiency. So alcoholics, they have B1 deficiency. Okay, Korsakoff syndrome is seen in alcoholics. And because of their alcoholism, you get B1 deficiency. And B1 deficiency causes amnesia. And the type of amnesia they have is anterograde, which is what? They can't form new memories. And they don't remember things uh, after after their head injury. Like they may fall and hit their heads, and they won't remember um, they won't remember incidents or conversations or new information after that head injury. So they remember old things like before when they were younger, but not new things. Korsakoff syndrome is associated with the disruption and destruction of the limbic system, especially in mammillary bodies, and the anterior thalamus. We'll get into this when we get into neuro. Um, this is seen in alcoholics as a late neuropsychiatric manifestation of Wernicke's encephalopathy. Confabulations are characteristic. What is confabulations? You make things up. They don't remember, so they make things up when they believe it's true. That's confabulations are seen in alcoholics. Okay, next. Depersonalization, derealization disorder. This is persistent feelings of detachment or estrangement from one's own body, thoughts, perceptions, and actions. That is depersonalization, or one's environment. That's derealization. The intact reality testing. So intact reality testing versus psychosis. So they're intact with the reality. Somebody who you know is, is undergoing depersonalization or derealization, their reality is intact. It's just they have feelings of detachment from one's own body. Okay, one's own body. They may have like a out of body experience, but that doesn't mean they're not um, unaware of reality. Now, um, they can have feelings of detachment from their own environment. That's a derealization. But remember, the reality is there. But in psychosis, reality is not there. They're out of touch with reality in psychosis. Dissociative amnesia. This is the inability to recall important personal information, usually following severe trauma or stress, may be accompanied by dissociative fugue, which is abrupt, unexpected traveling away from home. Okay, so dissociative amnesia is we can't remember things like your own information, like your own birthday, your name, and this is usually following severe trauma or stress. Um, Dissociative fugue can be accompanied by that, like with that, with the dissociative amnesia. This is when someone travels far away from their house randomly, and they're not able to, um, I believe, give you information about themselves. Give me a sec. Yeah. So dissociative fugue is like it's a form of dissociative amnesia, sudden, unexpected travel, and an ability to call past experiences or who they are. Okay, so that's that. And dissociative identity disorder, formerly called multiple personality disorder, is the presence of two or more distinct identities or personality states. So when somebody has two or more different personalities. It's more common in women. This is associated with the history of sexual abuse, PTSD, depression, substance abuse, borderline personality, and somatic symptom disorders. This is incredibly vague. Dissociative identity disorder. Um, it's I've never seen it. Um, I've only heard about it because I've been in I've been working on and off the psych ward, um, different psych units. I've never seen it, and I wish I wish I had, but it's incredibly rare. So is that dissociative amnesia. Like dissociative fugue is also very rare. Okay, so delirium. Delirium is how you have to know. Waxing and waning, level of consciousness with acute onset, decreased attention span. There is a decreased level of arousal. Delirium is characterized by disorganized thinking, hallucinations, often visual, misperceptions, like illusions are there, disturbance in sleep-wake cycle, and there's cognitive dysfunction, agitation. Delirium is reversible. Delirium usually is secondary to other identified illness, like CNS disease, infection, trauma, substance abuse, withdrawal, metabolic disturbances, hemorrhage, urinary fecal retention, or medications like anticholinergics, anticholinergics, especially in the elderly. Most common presentation of altered mental status in inpatient setting, especially in the ICU or during prolonged stays in the hospital. EEG may show diffuse background rhythm slowing. Delirium is changes in the sensorium. Treatment is identification and management of underlying condition. Orientation protocols, like keeping a clock or calendar nearby, decrease sleep disturbances, and increase cognitive stimulation to manage the symptoms. Antipsychotics are needed. Avoid unnecessary restraints and drugs that may worsen the delirium, and avoid anticholinergics, benzodiazepines, and opioids as they worsen delirium. Okay, now we're just going to break it down. Waxing and waning. So they are in and out of consciousness. Okay, so with acute onset. Okay, so it happens rapidly, comes fast. Acute onset. There is decreased attention span. They're not easily arousable. Uh, they have delirium patients. They have disorganized thinking, hallucinations, which are often visual, because in schizophrenia, hallucinations are often auditory, but in delirium, they see things. Uh, they have misperceptions like illusions. Um, Disturbance in sleep-wake cycle. They have trouble sleeping and waking up. Cognitive dysfunction, agitation. Okay, and they also delirium is reversible. Delirium is usually due to another illness, like a central nervous system disease, infection, trauma, substance abuse like alcoholism, withdrawal of alcohol, metabolic electrolyte disturbances, hemorrhage, urinary fecal retention. So if they're constipated or they can't pee, that can cause delirium, or medications like anti parasympathetic medications. So anticholinergic medications, right? Um, that would be anticholinergic drugs. Is a class of medications that block the action of the neurotransmitter anti-acetylcholine. So basically, these are like any drugs that block the sympathetic system. This would be Benadryl. Okay, so diphenhydramine, oxybutynin, amitriptyline, and scopolamine. These are four common anticholinergic drugs that make delirium worse. I'm gonna make a note of this. Diphenhydramine, oxybutynin, amitriptyline, which is a TCA, amitriptyline, amitriptyline, and scopolamine. Okay. All worsen delirium. All worsen delirium. Okay. Okay. So next we have the most common presentation is altered mental status in inpatient setting, especially in the ICU, or during prolonged hospital stays. That's where you see delirium most often. It presents like altered mental status. They're confused. Delirium patients are confused, and where it happens is the inpatient in the hospital, um, especially in the ICU, and during very long stays in the hospital. ECG may show diffuse background rhythm slowing. Okay, remember that. Diffuse background rhythm slowing. Not sure if you really need to know how to read it, because I don't. But if you just want a general picture, this is what it looks like. Okay, so slowing. So I guess these are like very rapid, right? These are very rapid and fast movements, but here it'll be like not so fast. It'll be more slow. You don't see as many ridges, I guess. Like, see this? There's a lot of ridges here, and this is slowing over here. So slowing on EEG. That's seen in delirium. Okay. Um, Delirium changes in the sensorium. Treatment is identification and management of underlying conditions. So basically, to treat whatever is causing the issues, whether that's a CNS disease, infection, trauma, or substance abuse, withdrawal, metabolic electrolyte disturbances or hemorrhage, or if they are constipated or can't pee. Okay, so remember that. So the treatment for delirium is to treat the primary issue that's causing the delirium. Orientation protocols: keep a clock or calendar nearby because they lose sense of time and night and day. So keep a clock or calendar nearby for the patient. Hold on. Okay. Decrease sleep disturbances. So um, do things that won't sleep, won't cause issues in their sleep cycle, and increase cognitive stimulation to manage symptoms. Okay. Antipsychotics as needed. And then the other way to treat delirium is to avoid unnecessary restraints and drugs like diphenhydramine that worsen delirium, or anything that blocks the parasympathetic system. Okay, and benzodiazepines, don't give them that. And opioids, do not give them opioids. Okay, next. Okay, so here we have psychosis. Distorted psychosis is a distorted perception of reality characterized by delusions, hallucinations, and/or disorganized thought speech. Can occur in patients with medical illness, psychiatric illness, or both. So psychosis, they're not in touch with reality. You have some people with psychosis have delusions, hallucinations, disorganized thoughts and speech. We're gonna get into that soon. Delusions, what are they? They are false, fixed, idiosyncratic beliefs that persist despite evidence to the contrary and are not typical of a patient's culture or religion. Patient example will be patient who believes that others are reading his thoughts. Types include erotomaniac, grandiose, jealous, persecutory, somatic, mixed, and unspecified. So delusions are false, fixed, idiosyncratic beliefs that persist despite evidence to the contrary, are not typical of a patient's culture or religion. So someone who believes that others are reading his thoughts is delusional. And there are different types of delusions. Erotomanic, which is like you believe that a celebrity is in love with you. Grandiose, you believe you're special and were sent to save the world, right? So there are people who've come to the word and they actually believed they were like a religious figure and they're here for the world, but they have one savior. It's not. So they had grandiose delusions. They were jealous, persecutory. So there's jealous type, which is let's see, jealous delusion. It's a good example of jealous type of delusion. So jealous delusions is a type of delusion or disorder where an individual is convinced, despite evidence to the contrary, that their partner is unfaithful. So yeah, they believe that the partner is cheating on them. I'm making note. Believes partner is cheating on them. Persecutory. Okay. Now next we're going on to persecutory. A persecutory delusion is a type of delusional belief where someone firmly believes, despite lack of evidence, they are being targeted, harassed, or mistreated by others. Okay. Targeted. Believes they are being targeted. Somatic and mixed and unspecified. Okay, let's look at somatic. Somatic is a somatic delusional disorder involves a persistent false belief that something is wrong with a person's body or its functions, often involving imagined physical ailments or deformities. Okay, so they actually believe there is something wrong with them physically, despite evidence that there's nothing wrong with them. Okay, make a note. Somatic delusion Yeah, so somatic delusion is when you have body elements, you believe you have body elements, despite being shown evidence you don't. And then erotomanic, to erotomanic, erotomanic. Yeah, erotomanic is a delusion in which you believe another person, someone usually of a higher status, you believe they're in love with you, despite lacking evidence to support the belief. Oh my, yes. Okay. So what is mixed? What is mixed? Oopsies. So in a mixed type, um, refers to mixed type refers to a subtype where no single delusional theme predominates, and a person experiences multiple types of delusions without one being more prominent than others. So yeah, so basically, in mixed type, you have an array of delusions. Um, it doesn't specifically fall into any one of the categories we just discussed. You could have a bunch of them together. So one is not more than the other. They have a bunch of mixed. You know, maybe they'll be jealous. They believe that the partner's cheating on them. Maybe they'll have grandiose delusions also. They think that they're special and they're better than everyone else. And somatic. They might also believe they have like something wrong with them and want many tests. They might believe they are being targeted unnecessarily, participatory. Okay, so disorganized thought. Speech may be incoherent, like word salad, as in word salad, um, tangential or derailed, like when you have loose associations. The disorganized thought is seen in schizophrenia. Speech may be incoherent. So incoherent is like word salad is like they say a bunch of words that don't make sense. Like they say like 10, 20 words that absolutely don't make sense. Like um, that have no relation to each other. What is word salad? What is word salad? It's a meaningless jumble of words and phrases in spoken language. So if I were to give an example, it would be purple bicycle singing happily tree elephant. Trees screamed broken glass, running lately people purpose purple. Bag stained purple vacuum. So that is an example of word salad. There is absolutely no sense in what they're saying. Tangential. What is tangential? So tangential is um, when the patient has a wandering train of thought and has an inability to return to the original topic. So they deviate from the main topic and they don't come back to it. Um, like it's a bunch of unrelated ideas. Um, for example, you ask someone, "What did you do? What did you do last weekend?" You respond with, "Well, I went to the park and then I saw a dog, and my dog used to be really fat, and then um, the dog died because it got hit by a car, and they never mentioned what they did last week." So it's like they go. You know when people say they go off on a tangent, tangential is something like that. They deviate from whatever you ask them. Loose associations. Loose association is is a thought disorder that involves speech with unrelated or barely connected ideas. Example would be I like to dance, my feet are wet. So it's like jumping from topic to topic with no connection between the two ideas. Okay. So let's see. Make a note. So yeah, so loose association is a form of disorganized thought. It's when you jump from idea to idea with no relation between the two ideas. Like I just said, I like to dance. My feet are wet. Okay, next, hallucinations. Hallucinations are perceptions in the absence of external stimuli, like seeing a light that is not actually present. Contrast this contrast with misperceptions, like illusions of real external stimuli. Types include auditory, more commonly due to psychiatric illness, like as seen in schizophrenia, then medical illness. Visual, more commonly due to medical illness, uh, like drug intoxication, delirium, then psychiatric illness. Tactile, common in alcohol withdrawal and stimulant use. Cocaine crawlies, a type of delusional parasitosis. Olfactory, often occur as in oral or temporal lobe epilepsy, burning rubber, and in brain tumors. Gustatory, rare but seen in epilepsy. Hypnagogic, occurs while going to sleep, sometimes seen in narcolepsy. Hypnopompic, occurs while waking from sleep, get pumped up in the morning, sometimes seen in narcolepsy. So what is this? This means so hallucinations are perceptions in the absence of external stimuli. There's nothing causing um, there's nothing causing you to see what you see. There's no there's no source in the real world causing you to see what you see, but you see it. Um, like seeing a light that is not actually there. Contrast with misperceptions, like illusions of real external stimuli. Okay. Contrast with misperceptions, illusions of real external. Yeah, so hallucinations are something that are not there, and this is different with illusions of real external stimuli. So basically, somebody could have moved and you saw a shadow, right? Like that's an illusion. Like it was caused by somebody moving, right? And this is different from hallucinations, as hallucinations have no external stimuli, whereas illusions do. So delusions are abnormal, illusions are normal. Okay, hallucinations are abnormal, delusions are abnormal, and um, okay, so hallucinations are abnormal, delusions are abnormal, but illusions are normal. So I hope I said that right. Hallucinations are abnormal, delusions are abnormal, but illusions are normal. Okay. All right. So types include auditory hallucinations. This is seen in schizophrenia, then other diseases like medical diseases. Schizophrenia is a mental disorder, and auditory hallucinations is prominent in schizophrenia more than visual hallucinations. Now, in visual hallucinations, where people see visual hallucinations, that would be in delirium or drug overdose, as opposed to mental disorders. Tactile hallucinations are common in alcohol withdrawal and stimulant use. Stimulant use. So, tactile hallucinations are things that you feel. You feel bugs on you. Um, this is common in alcohol withdrawal. When you're coming out of alcohol withdrawal, you feel things on you. And stimulant use. When you um, overdose on cocaine, let's see, cocaine crawlies. Yeah, so cocaine crawlies is from chronic cocaine use, and oh my goodness, chronic cocaine use can cause psychosis, which can cause something known as formication, and that formication causes you to feel bugs crawling on you, also known as cocaine crawlies. Okay. Okay. So that's a delusion. Okay. It's a tactile hallucination, and it is also a delusion that bugs are crawling on you. Olfactory hallucination um, occurs as an aura of temporal lobe epilepsy. You smell burning rubber, and you also see olfactory hallucinations in brain tumors. Yeah. So temporal lobe epilepsy, burning rubber, gustatory hallucinations. So that's rare. It's when a person perceives taste that's not there in reality. It's seen in epilepsy. Hypnagogic. That's a hallucination that happens when you're going to sleep. So remember, go in hypnagogic and going to sleep. And it's sometimes seen in narcolepsy. Hypnopompic occurs while waking up from sleep. Get pumped up in the morning. That's a good way to remember first aid cues. Pump, right? Pumped up in the morning. It occurs while you're waking up from sleep. Um, it's also sometimes seen in narcolepsy. Okay, next we have schizophrenia. So, schizophrenia is a chronic illness uh, causing profound functional impairment. Symptom categories include positive symptoms, which are hallucinations, delusions, unusual thought process, disorganized speech, and bizarre behavior. Negative symptoms are flat or blunted affect, apathy, anhedonia, alogia, social withdrawal. Cognitive symptoms are reduced ability to understand or make plans, diminished working memory, and inattention. Diagnosis requires two or more of the following active symptoms, including one or more from symptoms 1 to 3. So, delusions. These are 5 symptoms for schizophrenia. Uh, Delusions, hallucinations, often auditory, disorganized speech. Number 4, disorganized or catatonic behavior. Number 5, negative symptoms. Schizophrenia requires one or more month of active symptoms over the past 6 months. Onset is equal to is equal to, okay, onset for 6 or more months prior to diagnosis. Okay. Um, Schizophrenia is associated with altered dopaminergic activity, increased serotonergic activity, and decreased dendritic branching. You see ventriculomegaly on brain imaging. Lifetime prevalence is 1 to 5%. Males have a greater chance than females. Presents earlier in men, late teens to early 20s, than in women, late 20s to early 20s, late 20s to early 30s. There's increased suicide risk. Heavy cannabis use in adolescents is associated with increased incidence, a worsened course of psychosis, mood, and anxiety disorders. Treatment is atypical antipsychotics like risperidone are first line. Negative symptoms often persist after treatment despite resolution of positive symptoms. Okay, so what this means is schizophrenia is a chronic illness. It's lifelong, there's no cure. Functional, it causes severe functional impairment. The symptoms include positive symptoms. What are positive symptoms? I like to think of positive symptoms are things that are added onto the person. So, like something that is added onto them, like hallucinations, is something that they see, right? It's like an extra thing that they see. Delusions, they have uh, false fixed beliefs, like someone is monitoring them, like somebody implanted a device in their head. These are delusions, right? They have unusual thought process, and these patients have disorganized speech, right? What is disorganized speech? Remember, we talked about loose associations, tangentiality, word salad. These are all disorganized speech and bizarre behavior. So this is disorganized behavior. So disorganized behavior is like sleeping in in the shed, or like, yeah, sleeping in the shed, not um, okay, and then like throwing their own feces, absolutely what is it, bizarre behavior, disorganized behavior. Negative symptoms, I would say negative. I like to think of negative symptoms as something that's taken away from you. So someone, like a normal person, is supposed to have a range of emotions, right? Happy to sad to angry. They're supposed to, have a whole. range of emotions, but if somebody is taken away, if someone's happiness is taken away, or someone's regular emotion that somebody's supposed to have, they're gonna look very flat. They typically have no expression on their face. I'm gonna show you what that looks like. Okay. So this is flat effect. So they don't have much emotion on their face. Blunted effect. So you see, this person is happy. This person looks kind of dubious. These are all normal emotions of a normal person. But somebody living with schizophrenia, they typically don't have an expression, or they have very, yeah, no expression. So these are all signs of flat effect. Okay, yeah, flat effect. Okay, next, apathy. What is apathy? Apathy is a lack of interest or concern. Okay, so it just means that they lack enthusiasm. Lack enthusiasm. Enthusiasm. Anhedonia. They lose. They don't. Loss of interest. Okay. Alogia. It causes you to speak less. Very few words. Limited speech. So you might ask them, "How was your day?" And what are some of your interests? They might say, "Good." Okay. So alogia, limited speech. Social withdrawal. They typically live in isolation. Okay. Cognitive symptoms. Reduced ability to understand or make plans. Diminished working memory, inattention. They can't pay attention. Okay. So this is due to um, structural brain deficits in schizophrenia. Diagnosis: you need two of the following symptoms to be diagnosed with schizophrenia, with one of the two symptoms being from either delusions, hallucinations, or disorganized speech. So Yeah, you need two symptoms, with one of them being delusions or hallucinations or disorganized speech, and the second one, the second symptom can be disorganized behavior or negative symptoms. And you need this uh, for 1 or more months over the past 6 months. And the symptoms need to be active. They need to be actively having uh, two of these symptoms for 1 month or more over the past 6 months. Onset is greater than 6 or months prior to diagnosis. So that you need to be having these symptoms for at least 6 months before someone can formally diagnose you with schizophrenia. And in those 6 months, you need one month of active symptoms out of these five symptoms. Yeah, requires 1 or more month of active symptoms over the past 6 months, and you need to be diagnosed. You need to be diagnosed with schizophrenia. You need 6 or more months of symptoms of these symptoms before diagnosis, right? On and off, 6 months. Schizophrenia is associated with altered dopaminergic activity. Typically, if there's an increase in dopamine, there's an increase in serotonin, and decreased dendritic branching. Ventricular megaly, so you have large ventricles on the CT scan in somebody with schizophrenia. Lifetime prevalence is 1.5%. Males have greater chance than females. Presents earlier in men, late teens to early 20s, than in women, late 20s to early 30s. So men typically have symptoms in late teens to early 20s. Women, it's late 20s to early 30s. There's increased suicide risk. Heavy cannabis use in teenage years is associated with increased incidence and worsened course of psychosis, mood, and anxiety disorders. Treatment is risperidone. Um, Negative symptoms often persist after treatment, despite resolution of positive symptoms. Okay, so you can give the um, risperidone, and that will take care of the hallucinations, like the positive symptoms. That will take care of the delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, or yeah. So these are the positive symptoms. It will take care of that. Um, but the negative symptoms will still be there. So negative symptoms often persist. What are the negative symptoms? Things that you take away from the patient, right? Things that are taken away from the patient. So flat affect, apathy, loss of interest, alogia, yeah, so limited speech, withdrawal, social isolation. All that will be there. There's no treatment for that. Okay, so brief psychotic disorder. Brief psychotic disorder is one or more positive symptoms lasting less than 1 month, usually stress related. Greater than one or more positive symptoms lasting less than 1 month. Okay, so what this means is, in brief psychotic disorder, it looks like schizophrenia, and you have one or more of these five symptoms that we said right here, lasting less than 1 month, usually stress related. So I think a brief psychotic disorder as a baby schizophrenia. You just It doesn't fully meet the criteria for schizophrenia. It's usually stress related. It's kind of like a psychotic break. You have one or more positive symptoms. So you you have delusions. or hallucinations, or disorganized speech, or disorganized or catatonic behavior for less than 1 month due to some stressor in life, and then it goes away. Okay, so catatonic behavior, this is what this is. Catatonic behavior is something like this. They stay in one position for hours, sometimes even days. They stay in a very rigid position. I've actually seen this, and it's very hard to um, actually see something like this because they don't eat, they don't do anything, and often we need to intervene. So yeah, okay, so schizophreniform disorder is when you have 2 or more of the symptoms lasting 1 to 6 months. Okay, so schizophreniform disorder is like almost schizophrenia. You have 2 or more symptoms from this list of 5, lasting between 1 to 6 months. So this is different from schizophrenia in that it can be any 2 of the symptoms. In schizophreniform, it can be any 2 of the 5 symptoms, but in schizophrenia, you need a symptom from symptom 1 to 3, and the criteria for schizophrenia was the time frame. So it's like the most important thing is time frame, how long they have had symptoms. In schizophrenia, you need more than 1 month of active symptoms. All these symptoms, like two or more of the list of 5 symptoms, need to be there for more than 1 month. At least 1 month or more than 1 month, it needs to be there. Over the past 6 months, onset of the symptoms is greater than 6 months before diagnosis. Yeah. But then schizophreniform is between 1 to 6 months, and you don't need 1 month of active symptoms. It's like they have it on and off. Okay, continuing with schizophrenia spectrum disorders, we have schizoaffective disorder. This shares symptoms with both schizophrenia and mood disorders, like major depressive disorder or bipolar disorder. To differentiate from mood disorder with psychotic features, patient must have more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay, so schizoaffective disorder is actually really hard to diagnose. This disorder shares the symptoms with both schizophrenia and mood disorders like major depressive disorder and bipolar disorder. To differentiate from a mood disorder with psychotic features, patient must have more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay, so schizoaffective disorder has both. It's like part schizophrenia and part bipolar disease, um, or major depressive disorder. So there's the way you classify the like schizoaffective disorder, major depressive type, or schizoaffective disorder, bipolar type. Um, what so if it's schizoaffective disorder, bipolar type. Okay, so schizoaffective disorder is a combination. So it shares symptoms with schizophrenia and mood disorders. What are mood disorders? Mood disorders are either major depressive disorder or bipolar disorder. Okay, so to differentiate schizoaffective disorder from a mood disorder with psychotic symptoms, a patient must have more than 2 weeks of psychotic symptoms without a manic or depressive episode. Okay, so basically, what they're saying is to differentiate schizoaffective disorder from a mood disorder with psychotic features. For example, a mood disorder with psychotic features would be bipolar 1 with psychotic features, right? So that is a diagnosis by itself. Bipolar 1 with psychotic features is a form of bipolar disorder, not schizoaffective disorder. So that is where someone is manic and they also have psychotic symptoms. What are psychotic symptoms? Hallucinations, delusions. These are all psychotic symptoms. So that would be bipolar disorder with psychotic symptoms. And that is the diagnosis, right? So to differentiate bipolar 1 disorder with psychotic symptoms and schizoaffective disorder, to differentiate these two disorders, you would need to have um, more than 2 weeks of purely psychotic symptoms without a manic episode or a depressive episode. That is how you get schizoaffective disorder. So basically, you would have to monitor this patient, and if they present with only um, schizophrenia, like schizophrenic symptoms, which is what um, delusions, hallucinations, disorganized speech, disorganized behavior, catatonic behavior, and negative symptoms. These are all symptoms of schizophrenia. If this patient has these 5 symptoms, or majority of the symptoms, for more than 2 weeks, without a single episode of mania or depression, we're going to get into the symptoms in a bit, then that person has schizoaffective disorder. And during the majority of that patient's life, that patient also presents with mania or like either mania or depressive episodes along with psychotic features. Um, so that's how you diagnose this patient with schizoaffective disorder. Again, this is very hard to diagnose. I think I've seen it one time in my entire life as a student. Um, Again, even the doctors couldn't definitively say if this was bipolar with psychotic features or schizoaffective disorder, and then eventually they monitor the patient for long enough to understand the patient indeed did have schizoaffective disorder. So, yeah, it is not an easy diagnosis. That's why this requires a little bit of explanation. So, what is schizoaffective disorder? Schizoaffective disorder is a disorder in which there is both schizophrenia and um, um, bits of major depressive disorder and bits of bipolar disorder, and you combine all this together and you get schizoaffective disorder. Okay, but the only differentiating factor between this schizoaffective disorder and a mood disorder with psychotic features, such as major depressive disorder with psychotic features or bipolar 1 with psychotic features. To have schizoaffective disorder, you need the patient to have more than 2 weeks of purely psychotic symptoms, which are delusions, hallucinations, disorganized speech, or disorganized or catastrophic behavior, and negative symptoms, without any episode of mania or any episode of depression. Okay, next, delusional disorder. This is when you have more than one or more delusions lasting for over 1 month, but without a mood disorder or other psychotic symptom present. There is a daily functioning, including socialization, may be impacted by the pathological fixed belief, but is otherwise unaffected. Can be shared by individuals in close relationships. Fully do. So, so here the daily functioning, so including socialization, may be impacted by pathological fixed belief, but is otherwise unaffected. Okay, so basically, with delusional disorder, you have to have more than one delusion, one or more delusions lasting for over a month. You have a delusional disorder. So basically, these individuals can go to work, they function, they look fine, they're able, they go to the office, they take care of themselves, but they have a fixed irrational belief that either someone is following them, or somebody's following them, or um, there actually are aliens, and aliens are going to take over the world. These individuals have like these irrational beliefs, but they can function fine, and these beliefs affect socialization, because they don't. If they believe someone is following them, they may not want to be out too long. They might not. They may keep a very close circle, social circle. And I'm gonna look up what folia do is. One sec. Folia do refers to a rare psychiatric syndrome where a delusional belief is transmitted from one person to another in a close relationship. It's a shared psychotic disorder or shared delusional disorder. So it's when two or more people in a close relationship share similar delusional beliefs. Couldn't make a note of this. Okay, so basically a husband and wife can both believe that they're being followed by aliens. That'll be folia do. Schizotypal personality disorder, cluster A personality disorder that also falls on the schizophrenia spectrum. Schizotypal personality disorder may include brief psychotic episodes like delusions, but are less frequent and severe than in schizophrenia. So this is a cluster A personality disorder. We're going to get into that. Um, this also falls on the spectrum of schizophrenia disorder. Um, this is where the patients have beliefs that, uh, usually delusions, that they can, if they wear a yellow shirt, they can control the weather. Like if they wear a yellow shirt, they can control tomorrow that the weather will be sunny. Um, that would be a delusion. So that are less frequent and severe. So these individuals, they can function fine. Schizophrenia, majority of the time they cannot function by themselves. Um, but schizotypal personality is like they believe that they can control things. Um, you know, according to their mood, emotions, things that they wear, things that they do. So these are all delusions. Okay. Next, we have mood disorders. What are mood disorders? Mood disorders are characterized by abnormal range of mood or internal emotional stress and loss of control over them. Severity of the moods can cause distress and impairment in social and occupational functioning, includes major depressive disorder, bipolar disorder, dysthymia, and cyclothymic disorder. Episodic superimposed psychotic features like delusions, hallucinations, disorganized speech, behavior may be present. Okay. So, what mood disorder is? It's a abnormal range of moods or internal emotional states and a loss of control over them. So severity of the moods causes distress, impairment in social and occupational functioning. So they can't. It's hard for them to maintain social circles and get by work. They have issues at work also. Includes major depressive disorder, bipolar disorder, dysthymia, cyclothymia, um, episodic superimposed psychotic features like delusions, hallucinations, disorganized speech, and behavior. Okay, so mania. So next we have a bunch of mood disorders that we're going to talk about. So mood disorders, there's like 5 or 6 types of mood disorders we're going to get into. Um, Here, all this was under the schizophrenia spectrum. Okay. So what's under schizophrenia spectrum? Schizophrenia, schizoaffective disorder, delusional disorder, schizotypal personality disorder. Next is a complete different category. It's called mood disorder, and mania is a type of mood disorder. Okay. And a manic episode is defined as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and increased activity or energy lasting 1 or more weeks. Uh, a diagnosis requires hospitalization or marked functional impairment with 3 or more of um, the following criteria. It's the first one is distractibility. Second one is impulsivity or indiscretion, um, which is when the patient seeks pleasure without regard to consequences. Or the next one is grandiosity, where somebody has an inflated self-esteem. The next criteria is flight of ideas, where you have racing thoughts, an increase in goal, um, and also an increase in Okay, racing thoughts is one. The next criteria would be an increase in goal-directed activities and increase in psychomotor agitation. And the next criteria is that there is a decrease in need for sleep. And the last criteria is pressured speech, which is you talk very very fast, and it's like a specific type of rhythm in which manic patients talk. You can look it up on YouTube. Um, okay, so we're gonna get into this. So to be classified as somebody having a manic episode, they need to have an elevated mood, right? Like usually, like they're very, for lack of a better word, hyperactive, um, or irritable. They're very, they're very easily get, they easily get irritated, and there's an increase in activity, like energy levels. There's increased activity or energy levels lasting 1 week or more. The diagnosis requires hospitalization. So mania is a psychiatric emergency. They do need to be hospitalized because they are a danger to themselves and other people. But when there's somebody's having a manic episode, they're very um, prone, uh, like they blow all their savings. That's like an act of impulsivity, right? So they end up blowing all their savings. They are very impulsive. Um, they get into accidents because they don't have regard for anything. They're not aware of their consequences, and they end up getting into car accidents. Um, they can self harm. They can harm other people. So they do have to be hospitalized. Um, so this is DIGFAST. So this DIGFAST is an acronym for the criteria of mania. You need three. You need three or more of the following symptoms: distractibility. So these patients are easily distractible. And then they're also impulsive, where we gave the example of them blowing all their money. They don't have good judgment, right? And they can easily get into accidents. Grandiosity. They feel like they're on top of the world, and actually they feel like no harm can come upon them. Okay, and then next they have flight of ideas, so which is racing thoughts. Their mind is always racing, and they have psychomotor agitation. Is like they're very fast. They walk very fast. They talk very fast. Whatever goals that they have, if they have a goal in mind, they are um, they're very adamant on completing that goal, whether that be dangerous or non-dangerous. So they are a danger to themselves because they are not aware of their consequences of their actions. And there's a decreased need for sleep, so they don't need to sleep much. Um, or they can even go a few days without sleeping. Mania. And the pressured speech. Look it up on YouTube. Uh, and they're very talkative. Remember, you only need three or more of these symptoms to be diagnosed with mania, and the symptoms need to be present for 1 week or more. The mood needs to be elevated or irritable. Okay, next, hypomania. I think I have a hypomania as baby mania. Hypomania is not a psychiatric emergency. They don't need to be hospitalized, but it is similar to manic episode, except mood disturbance is not severe enough to cause marked impairment in social and or occupational functioning or to necessitate hospitalization. There is so Hypomanic episode is similar to a manic episode, except mood disturbance is not severe enough to cause marked impairment in social and/or occupational functioning, or to necessitate hospitalization. There is an abnormally increased activity or energy usually present. There are no psychotic features. Um, this hypomanic episode lasts 4 or more consecutive days. So you have to remember that it hypomania is like baby mania. Mania is a psychiatric emergency. Hypomania is not a psychiatric emergency. It has features of mania. Hypo is means what? Low, like a lower form of mania or a decreased form of mania. So this is similar to manic episode, except the disturbance is not severe enough to be is not severe enough to be hospitalized. It doesn't interfere with their daily functioning, but there is an expansive mood. There are no psychotic features. So means that there are no hallucinations. There is no disorganized speech. Okay, and hypomania lasts 4 or more days. Next, we have bipolar disorder. Bipolar disorder is classified um, into bipolar 1 and bipolar 2. Bipolar 1 is when there is increase. Okay, so there, for somebody to be diagnosed with bipolar disorder, you would have to have at least one episode of mania, with or without a hypomanic or depressive episode, and this mania can be separate from the hypomania um, or depressive episode by any amount of time. It doesn't have to. It doesn't happen. Doesn't need to happen right next to each other. Okay, so bipolar 2 is when there's hypomania and a depressive episode, but you can never have even one manic episode to be classified under bipolar 2. Okay, so in bipolar 2, the patient's mood and functioning usually normalize between episodes. Patient's mood and functioning usually normalize between episodes. The use of antidepressants can destabilize the mood. There's a high suicide risk. Treatment is mood stabilizers like lithium, valproic acid, carbamazepine, uh, carbamazepine, lamotrigine, atypical antipsychotics. So we have to. That's something you have to know high yield. So the high yield point in that is that you don't want to give bipolar patients antidepressants because it can induce mania, right? So, that's what this means. Use of antidepressants can destabilize the mood. So, if you give antidepressants, you can unstabilize them, and you can induce mania. Okay, so do not give antidepressants to bipolar patients. Instead, you give mood stabilizers like lithium, valproic acid, carbamazepine, lamotrigine, and atypical antipsychotics. Okay, so that's that. So bipolar 1, what is that? That is mania. If you just had one episode of mania, you are bipolar 1, and that's the only criteria you need actually to be diagnosed with bipolar 1 disease, an episode of mania. Um, they can have a hypomanic or depressive episode along with that, like with mania, um, within like a 1 year time. So basically, they could have mania like the first few months of the year, and later they could have a hypomanic episode. Like later towards the end of the year, they could have a hypomanic episode, and then at the end of the year, they could have depressive episode, but the hypomanic episode and depressive episode do not need to be there for someone to be diagnosed as bipolar 1, as long as they've had that one manic episode at the beginning of the year or any time throughout the year. That's what this means. May be separated by any length of time. Okay. All right. So that's bipolar 1 disease. Bipolar 2 is when you have hypomanic and a depressive episode. So you have hypomanic is right here. We discussed this. Hypomania, all this, right? That's hypomania. In bipolar 2, that's common, right? I mean, that's not common. It's a criteria. A hypomanic and a depressive episode. Depressive episode is like they have major depressive symptoms. We're gonna get into that in the next section. Okay, so it's bipolar 2. And patient's mood and functioning stabilize between episodes, and you don't give antidepressants in bipolar patients. Okay, remember that. Next, we have cyclothymic disorder. Cyclothymic disorder is a milder form of bipolar disorder, fluctuating between mild depressive and hypomania symptoms. Must last 2 or more years with symptoms present at least half of the time, with any remission lasting less than or equal to 2 months. Okay, yeah. Okay, so cyclothymic disorder is a milder form of bipolar disorder. This, both of these. So it's a milder form of bipolar disorder, fluctuating between mild depressive and hypomanic symptoms. Okay, so they fluctuate between depressive and hypomania episodes. Cyclothymia must last to more than 2 years or 2 years, with symptoms of depression and hypomania present at least half of the year. Half of the time. Okay, half of the year, with any remission lasting less than 2 months. Okay. So they can't be symptom free for less than 2 months. Okay, so I want to correct myself. I thought it was right when I said it, like initially when I thought about it, but first it is written in this strange way, where it says cyclothymia disorder must last more than 2 years, with symptoms present at least half the time, with any remission lasting less than or equal to 2 months. Okay, what this means is that cyclothymia, for someone to be diagnosed with cyclothymia, the symptoms of major depressive disorder and hypomanic symptoms must be present more than half of the year. Okay, so at least half of the year, it must be present, and this has to be ongoing, right? So someone must have depressive and hypomanic symptoms, and they have to be there at least half of the time. So half of 2 years is 1 year, or that's what that means. Okay, half of the year, or half of 2 years, but you can't be symptom free for more than 2 months back to back. So you have to have both depressive and hypomanic symptoms for at least half of the 2 years. But you can't be symptom free for more than 2 months at any given time. because then you wouldn't have cyclothymia. So realistically, if you think about it, if someone has to have they had to be hypomanic or depressive more than 2 years, and the symptoms must be there half of the time, but they can't be symptom free for less for more than 2 months. Okay, I personally find this is a harder diagnosis than schizoaffective disorder, because I feel like this is harder to actually diagnose. So somebody has hypomanic and depressive symptoms for 2 years, and they have to have hypomanic and depressive symptoms at least half of the 2 years. So let's say, okay, so they would have to have hypomanic and depressive symptoms for half 2 years, so 1 year. Let's say they consistently had symptoms for 1 year. So and then they can not no they can't have that either. How does that work? If they have symptoms for half of for the entire year, because that's half of the 2 years, but they're saying you can't be symptom free more than 2 months. So then the second year, because there's no symptoms, that will put you out of the cyclothymia. Okay, maybe it's like half. Maybe it's like half. You need a little bit of symptoms throughout the year, but you can't have. But those symptoms can't be symptom free. Like you can't have no symptoms for more than 2 months. Yeah, that's confusing. That's confusing. I hope I got that. Somehow it makes sense in my head, but I hope I explained it properly. Okay, but that is like people know that this one's hard. People know that cyclothymia is actually really hard to diagnose because it's confusing. So remember that one. It's like a milder form of bipolar disorder, um, where you have it's a form of milder form of bipolar 2 disorder, where you have mild depressive and hypomanic symptoms. You need to have it for at least 2 years. The mild and mild depressive and hypomanic symptoms, but you can't not have mild depressive and hypomanic symptoms for more than 2 months, which that is the diagnosis for, that is a criteria for cyclothymia. And the mild depressive and hypomanic symptoms must be there half of the time, so half of the 2 years. So if somebody has depressive symptoms and hypomanic symptoms for 1 year, and then doesn't have the mild depressive and hypomanic symptoms for the next year, you don't have cyclothymia, because you would have gone more than 2 months without mild depressive and hypomanic symptoms. So basically, when they say half of the time, it's like realistically, if you think about it, it would be like half a day. Like you would need to be either depressed or hypomanic half of the day, at least. So the symptoms must be there for majority of the day for every 2 years. I mean, for 2 years, but you can't be symptom free more than 2 months of those 2 years. Okay, now we have major depressive disorder. Um, these are recurrent episodes lasting 2 or more weeks, characterized by 5 or more of the 9 diagnostic symptoms. This must include depressed mood or anhedonia. How I learned it was Psychiatry, so that's what I'm going to go by. But first aid gives big space. For me, it was Siggy Caps, so I'm gonna pull that up to remember all the symptoms of major depressive disorder. So Siggy Caps. Um, you in major depressive disorder, you have sleep disturbance, usually increased sleep. You have loss of interest, which is also known as anhedonia. Um, Guilt. You have increased guilt and increased feelings of worthlessness. E. You have loss of energy. Uh, C. Concentration issues. So you can't concentrate like you used to. A. Appetite or weight changes. Usually it can go up or down, but it's usually increased weight, and they usually have increased appetite. P. Psychomotor activity. So psychomotor agitation or retardation. So they can be very fidgety, or psychomotor retardation is like they're doing things much slower than they used to. That's known as psychomotor retardation. S. Suicide ideation. And there is they have they have feelings of wanting to kill themselves. Okay, so this is a very severe disorder. Okay, so remember Siggy Caps. Okay, so we need 5 of the 9 symptoms we just talked about. They need to um, be lasting 2 or more weeks. Screen for previous manic or hypomanic episode to rule out bipolar disorder. Yeah, if they ever had a episode of mania, that would be bipolar disorder. Okay, and um, hypomania is a mix of. It's a mix of. Okay, hypomania is not a mix. Hypomania is similar to a manic episode, and bipolar 2 is a mix of hypomania and depressive episode. Okay, so for MDD, which is major depressive disorder, you have to rule out previous episode of mania to rule out bipolar 1 disease, and you have to rule out hypomania to rule out bipolar 2 disease. Treatment: cognitive behavioral therapy and selective serotonin reuptake inhibitors are first line. Um, from what I've seen, doctors uh, give either sertraline or fluoxetine as first line. They also give SNRIs, selective norepinephrine reuptake inhibitors, or mirtazapine, or bupropion, or and this other one is electroconvulsive therapy, but this is usually for it's last resort. It's expensive. Um, it's not readily available. Okay, so yeah. Next, MDD with psychotic features. So this is major depressive disorder with psychotic features. Here you have major depressive um, disorder and hallucinations or delusions. But the important thing to remember is that these hallucinations and delusions only happen during the depressive episode. Okay, so they see while they're having all these symptoms up here, at least 5 of them, they also hear things, um, and they have delusions. They believe things that are not there. Okay, but this hallucination and delusions are only during this episode of MDD. Yeah, psychotic features are typically mood congruent, like depressive themes of inadequacy, guilt, punishment, nihilism, disease, or death. Okay, so The psychotic features that they have, um, they're usually related to depression. Uh, like they don't feel like they're they're worth anything. They have increased guilt, um, punishment, nihilism. What is nihilism? And they have hallucinations and delusions related to death and disease, and these um, only occur in the context of major depressive episode. This is different from schizoaffective disorder, where symptoms um, so symptoms of bipolar disease and schizophrenia are there majority of the time, and they must and yeah, in schizoaffective disorder they must have 2 weeks without any mood symptoms. So they must have 2 weeks without any MDD episode or without any manic episode. But other times they have hallucinations. Other than the 2 weeks, they have hallucinations and delusions present. But in MDD with psychotic features, the MDD, the hallucinations and delusions are only present during the MDD episode. But in schizoaffective disorder, you need 2 weeks without any. You need 2 weeks of psychotic symptoms without any mood disorders. So 2 weeks of psychotic symptoms without any mania or depression. They need to be actively having psychosis, so actively hearing things, having delusions that are not, that's not related to mania or any depression, and that would be schizoaffective disorder. The treatment is antidepressants with the treatment for MDD with psychotic features would be antidepressant with atypical antipsychotic or electroconvulsive therapy. Nihilism is a collection of views that reject aspects of existence, ranging from mortality and the meaning of life to political institutions. Okay, so nihilists. It's rejection of inherent value, meaning, and purpose of life. Oh wow, they believe that everything is ultimately meaningless. Oh my goodness, that's that's very sad. Okay. I'm making a note. Okay, next we have persistent depressive disorder. This is also a dysthymia. This is milder than MDD, so this is milder than major depressive disorder. You have to have two or more other depressive symptoms lasting 2 or more years, and in children, you need two or more of the depressive symptoms lasting more than 1 year or 1 year, and that's for kids. But adults, you need two or more depressive symptoms of MDD lasting 2 or more years, and you can't be symptom free for more than 2 months. So technically, you can say cyclothymia is like dysthymia and hypomania put together, because cyclothymia is a mix of mild depression, which is right here, mild depression, milder than MDD. Yeah, so cyclothymia is a mix of mild depression and hypomania. So technically, you can say cyclothymia is a mix of dysthymia and hypomania. It's just that times you have to know. You have to make a note of. So the difference between cyclothymia and dysthymia is that in dysthymia there is no hypomania. They're only um, depressive. But you only need 2 of the 9 criteria of MDD for 2 years um, in dysthymia. And you can't be symptom free for more than 2 months. Okay, so and then next we have MDD with seasonal pattern. This is formerly called seasonal affective disorder. There is major depressive disorders occurring only during a particular season, usually winter. Usually winter, in 2 or more consecutive years, and in most years across a lifetime. Okay, so you have symptoms of major depression only only during a specific time, which is usually winter, so no sunlight makes people sad. Um, and this has to be going on uh, for 2 consecutive years, and in most years during one's lifetime, or you're chronically sad during the winter. Most of the patient is chronically sad. Next, we have depression with atypical features. This is characterized by mood reactivity, transient improvement in response to positive event, hypersomnia, hyperphagia, leaden paralysis, which is the heavy feeling in the arms and legs, long-standing interpersonal rejection sensitivity, most common subtype of depression. Treatment is cognitive behavioral therapy and SSRIs are first line. MAO inhibitors are effective, but not first line because of the risk profile. We'll get into that. This is characterized by so this is the most common subtype of depression. This is characterized by mood reactivity, um, which is transient improvement in response to the positive event. So their mood, um, they become happy. It changes, right? So their patient's mood becomes happy and elevated when something good happens. Okay, so that's mood reactivity. Um, Here they sleep a lot, and they also have increased appetite, so they eat a lot, and they have a heavy feeling in the arms and legs. Long-standing interpersonal rejection sensitivity. I have to look up what that is. Long. What is that? What is long-standing? What is long-standing? Interpersonal rejection sensitivity. So, long-standing interpersonal rejection sensitivity refers to a chronic tendency to to perceive and intensely react to real or perceived rejection from others. It often involves heightened emotional sensitivity, um, anxiety, and defensiveness in social interactions. People with this may interpret ambiguous or neutral cues as signs of rejection, which can lead to overreacting, withdrawing, or become preemptively hostile. So it's when someone perceives someone perceives that they are not liked from someone. So basically, it's like a reaction to the thought of rejection. So it's a reaction to perceived. Yeah, it's a reaction to perceived or real rejection. Okay. Treatment is CBT and SSRIs. You can give MAO inhibitor, but they're not preferred due to the side effects. Okay. Next we have peripartum mood disturbance. So now we have peripartum mood disturbances, onset during or shortly after pregnancy or within 4 weeks of delivery. Uh, Increased risk with history of mood disorders. So, peripartum mood disturbance. So, this happens shortly after pregnancy or within 4 weeks of delivering the baby. And there is increased risk of peripartum mood disturbance with history of mood disorders. So, if somebody has a history of major depressive disorders and bipolar disease, they are both mood disorders. So you have an increased chance of getting peripartum mood disturbances. There's three types: maternal blues or postpartum blues. There's a 50 to 85% incidence rate, and this is characterized by depressive affect, tearfulness, and fatigue starting 2 to 3 days after delivery. Usually resolves within 2 weeks. Treatment is supportive. Follow up to assess for a possible major depressive disorder with peripartum onset. Okay, so characterized by depressive affect, so they look depressed, they're teary and tired 2 to 3 days after delivery. Then this is like a new mom syndrome. It goes away within 2 weeks, but you should always follow up to check for major depressive disorder with peripartum onset. Next, we have major depressive disorder with peripartum onset, and this is 10 to 15%. This has a 10 to 15% incidence rate. This is formerly called postpartum depression. The syndrome meets the criteria for major depressive disorder. Um, with yeah, this syndrome meets the criteria for major depressive disorder with onset no later than 1 year after delivery. Um, so they meet all the symptoms for MDD within 1 year after delivering baby. Treatment is CBT and SSRIs. I'm making a note of this. Okay. Next we have mm, postpartum psychosis. There is a 1.1 to 0.2% incidence rate. This is characterized by mood congruent delusions, hallucinations, and thoughts of harming the baby or self. Risk factors include first pregnancy, family history, bipolar disorder, psychotic disorder, recent medication change, treatment is hospitalization and initiation of atypical antipsychotics. If insufficient, ECT may be used. So postpartum psychosis, um, 0.1 to 0.2% incidence rate. It is characterized by mood congruent delusions. Yeah, so they have mood congruent. So whatever their mood is, they have delusions according to that. So if they're depressed, they have thoughts. They have delusions of related to death, pessimism, um, disease, and if they are manic during this time, they have delusions related to mania, grandiose delusions, hyperactive. Um, the mood is very elevated, so they have delusions related to that. And I'm trying to think of other delusions that are like related to mania. Yeah, it's usually grandiose delusions. They think they are on top of the world. So, in past postpartum psychosis, the person could either be depressive or manic, and they have their delusions are related to whether they are depressive or manic. They also have hallucinations and thoughts of harming the baby or self. Risk factors include first pregnancy, family history, bipolar disorder, psychotic disorder, recent medication change. Treatment is hospitalization and initiation of atypical antipsychotics. If insufficient, you have to give electroconvulsive therapy. Next, we have grief. The 5 stages of grief per Kubler-Ross model are denial, anger, bargaining, depression, and acceptance. Yeah. The 5 stages of grief per the Kubler-Ross model are denial, anger, bargaining, depression, and acceptance. May occur in any order. Other normal grief symptoms include shock, guilt, sadness, anxiety, yearning, and somatic symptoms that usually occur in waves. Simple hallucinations of the decreased person are common, like hearing the disease speak. Any thoughts of dying are limited to joining the disease? Any thoughts of dying are limited to joining the disease versus complicated grief. Duration varies widely. Usually resolves within 6 to 12 months. Persistent complex bereavement disorder involves obsessive preoccupation with the disease and causes functional impairment lasting at least 12 months, 6 months in children. Can also meet criteria for major depressive disorder. Okay, so the 5 stages of grief are what? Denial, anger, bargaining, depression, and acceptance. So let's see, D-A-B-D-A, DABDA, DABDA. So the first step is a denial, anger, then bargaining, depression, and acceptance. It can occur in any order, but this is typically the 5 stages of grief, and usually it's like that. Usually people deny in the first step. They always deny. Last step is acceptance. Other normal grief symptoms include shock, guilt, sadness, anxiety, yearning, and somatic symptoms that usually occur in waves. Somatic symptoms are uh, physical symptoms. You start having physical like pain, like your body starts hurting, your stomach starts hurting once you hear like really bad news. Uh, Simple hallucinations of the deceased person are common, like hearing them talk. That's a simple hallucination, and it's common. Any thoughts of dying are limited to joining the deceased. So it's normal, like wanting to die, like wanting to die after the loss of a loved one is normal, but it should only be one like feeling, oh, I'm better off dead. Like I wish I could be with them. That's like a normal thought process. But if somebody has a plan and they're actually trying to kill themselves, or um, they buy a gun or something, that's not normal grief anymore. That's complicated grief with increased suicide ideation. Okay, so that's different. Uh, so, yeah, any thoughts of dying are limited to joining the deceased. Wanting to die is normal. Wanting to die is normal, but having a plan is not. Is not. Is not. Okay, any thoughts of dying is limited to joining the dead versus complicated grief. Okay, duration of varies widely, usually resolves within 6 to 12 months. Persistent complex bereavement disorder involves obsessive preoccupation with the disease and causes functional impairment lasting at least 12 months, 6 months in children. Can also meet criteria for major depressive disorder. So, this is persistent complex bereavement disorder. It's like they're obsessively thinking about the person that has died, and they can't function, they can't do their daily chores, they can't, they're neglecting their personal hygiene, they can't go to work. Um, that's persistent complex bereavement disorder. Causes functional impairment. Okay, and lasts at least 12 months. And its children 6 months. Okay, they meet the criteria for MDD. Electroconvulsive therapy. Rapid acting method to treat refractory. Rapid acting method to treat refractory depression. That means like depression that will not go away with medicine. Persistent depression. So depression. What else can ACT treat? Depression with psychotic symptoms, catatonia, and acute suicidality. Induces tonic-clonic seizure under anesthesia and neuromuscular blockade. Adverse effects include disorientation, headache, partial anterograde retrograde amnesia, usually resolving in 6 months. No absolute contraindications, safe for pregnant and old people. Okay, so basically, this is a very good way to treat depression that cannot be helped with medicine. Um, Depression with psychotic symptoms, catatonia, which is something you see in schizophrenia. A person is stuck in a particular pose for hours, maybe even days on end. You need to intervene and help them, right? So that's catatonia. ECT can be used for that. Um, someone who is suicidal. It can also be used for ECT can also be used for that. What it does is that it induces a tonic-clonic seizure um, when after the doctors give you anesthesia, and you also get neuromuscular blockade. Adverse effects include disorientation, headache, partial anterograde and retrograde amnesia. So um, you you won't remember things after the incident. That's anterograde amnesia. Retrograde amnesia is that you won't remember old memories. Mm, yeah, you're gonna have either partial anterograde or retrograde amnesia after the electroconvulsive therapy. So anterograde amnesia, you won't be able to make new memories. You won't remember things after the procedure. And if you're affected by retrograde amnesia, when somebody gives you electroconvulsive therapy, you won't remember old memories. So you'll have retrograde amnesia. Results in 6 months. There are no contraindications. It is a really good treatment. It's just that it's expensive, not easily available. It is safe in pregnant and elderly people. Okay. Risk factors for suicide completion. Sad persons is the mnemonic. Sad persons. S stands for male. A is for age. D is for depression. P is for previous attempts, highest risk factor. E is for ethanol. R is for rational thinking loss. S is for sickness. O is for organized plan. N is no spouse or other social support. S is stated future intent. Okay. So, sad persons. Sex. So, basically, if you're a man, you have a higher chance of completing suicide. A, age, right? If someone's younger, a young adult, or very old, they have a more tendency for completed suicide. D is for depression. They have a history of depression. They have a higher chance for suicide, completed suicide. P is for previous attempt. That is the highest risk factor. If someone has previously attempted suicide, they're more prone to do it again. E is for ethanol or drug use. If someone drinks or has a history of drug use, they have a higher chance of completed suicide. R is for rational thinking loss. So they lose like somebody has a loss of judgment, or or if they experience a psychotic episode, they are more prone to have a um, completed suicide. They're more prone to do completed suicide. Um, if they have a sickness, they're more prone to do completed suicide. And if they have an organized plan, if they say that I want to, I think of shooting myself, think of jumping off a bridge. That is a plan. That is an organized plan. So you have to be very careful when someone says something like that. So, and no spouse or other social support. That's how loneliness can do this to you. If you lose the person that you have loved, or if you've never loved, and you're lonely, you have no social support. They feel like they have no one to live for, so they have a higher chance of completing suicide. That's the stated future intent. If they have previously said that they are going to kill themselves, you have to threaten you with it. Do not take that lightly, because that is one of the criteria. Stated future intent. Okay, sad persons are more likely to complete suicide. Most common method in the U.S. is firearms. Access to guns increase risk of suicide completion. Women try more often, men complete more often. Other risk factors include recent psychiatric hospitalization and family history of completed suicide. Someone has a family history of completed suicide, that is also a risk for someone else to do suicide. Anxiety disorders, inappropriate experiences of fear and worry, and their physical manifestations incongruent with the magnitude of the stressors. Symptoms are not attributable to another psychiatric disorder. A medical condition like hyperthyroidism or substance use includes panic disorder, phobias, generalized anxiety disorder, and selective mutism. So, so anxiety disorders uh, is where somebody has fear or worry, uh, and they they have physical symptoms that are uh, that are bigger or uh, that are much bigger than whatever their stresses are. Like their physical symptoms won't will be way out of proportion than whatever their stressors are. Here, symptoms of fear and worry uh, and physical symptoms cannot be due to a condition like substance abuse or hyperthyroidism. Anxiety disorders include panic disorder, phobias, generalized anxiety disorder, and selective mutism. Next, we have panic disorder. It's the first of the anxiety disorders. This is recurrent panic attacks involving intense fear and discomfort with or without a known trigger. Attacks typically peak in 10 minutes with four or more of the following: palpitations, paresthesias, depersonalization or derealization, abdominal pain, nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness of breath, strong genetic component, and increased risk of suicide. Okay, so panic disorder. The diagnosis requires attack followed by more than or equal to 1 month of one or more of the following um, conditions. Condition number one: there's a persistent concern of additional attacks. Number two, someone is worrying about consequences of attack. Number three, behavior change related to attacks. Number four, okay, so there's three. Um, Symptoms are systemic manifestations of fear. Treatment is CBT, SSRIs, and venlafaxine are first line. Benzodiazepines occasionally used in acute setting. Okay, panic disorder. There is a recurrent panic attack. So here there's recurrent panic attacks involving intense fear and discomfort with or without a known trigger. Attacks peak in 10 minutes with four or more of the following: palpitations, paresthesias. What is paresthesias? Abnormal sensations that can feel like tingling, burning, prickling, crawling on the skin. So paresthesias are pins and needles. Like you feel pins and needles in your feet, in your hands. Um, these patients, they have depersonalization and derealization, abdominal pain, nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness of breath, there is a strong genetic component to panic disorder, an increased risk of suicide. You have to have one of the three following symptoms um, or conditions um, for a month or more. Number one would be persistent concern of additional attacks. Persistent concern of additional panic attacks. Number two is worrying about consequences of a panic attack. Um, Number three, behavioral change related to attacks. Okay. Symptoms are systemic manifestations of fear. So they're always worried, they're scared. Fear. Treatment is CBT, SSRIs, and venlafaxine. First line benzodiazepines are given, but usually when someone's actively having a panic attack, we do not give benzodiazepines as maintenance medication because of high risk for um, dependency. Next, we have phobias. Phobia is severe, persistent fear or anxiety due to presence or anticipation of a specific object or situation. Person often recognizes fear is excessive. Treatment is CBT with exposure therapy. So severe phobia is severe, persistent fear or anxiety for 6 months or more due to the presence or anticipation of a specific object or situation. Okay, so you're scared, like phobia is an irrational fear. You're terrified of something for 6 or more months. Of a specific object or situation. Person often recognizes fear is excessive. Treatment is with exposure therapy or CBT. So you have social anxiety disorder. There is an exaggerated fear of embarrassment in social situations like public speaking, using public bathrooms. Treatment is CBT, SSRIs, venlafaxine for performance type. When you have to do public speaking and someone's very anxious, give beta blockers or benzodiazepine. Right? So when someone has a social anxiety disorder, where someone is scared or embarrassed of being in social situations, so they have trouble using a restroom, you give cognitive behavioral therapy or SSRIs or venlafaxine, which is an SNRI. For performance type, which is anxiety that's only seen in public speaking, give beta blockers or benzodiazepines. Okay. Make a note. Performance type, anxiety only in public speaking. Only in public speaking. Give benzodiazepine or beta blocker. Okay, so yeah, and in other situations where someone has a social phobia, like peeing in public bathrooms or public speaking, you give SSRIs. But if it's like public speaking only, like they're only anxious during public speaking, then that's performance type. Performance type Anxiety. So you only give a benzodiazepine or a beta blocker for that specific situation. Otherwise, you give SSRI or CBT or venlafaxine. Now, agoraphobia. Agoraphobia is an irrational fear or anxiety while facing or anticipating two or more specific situations, like open or closed spaces, lines, crowds, public transport. If severe, patients may refuse to leave their homes, sometimes for years. This is associated with panic disorder. Remember how we said people with panic disorder are they have persistent concern of additional attacks. They worry about consequences of the attack. Um, Behavioral change related to attack. So these patients, they might be too scared to go outside because they'll avoid going outside because they're afraid they're gonna have a panic attack outside. So that's how somebody becomes agoraphobic, when someone is too scared to go outside. Irrational fear or anxiety while facing or anticipating two or more specific situations like open or closed spaces, lines, crowds, public transport. So they're afraid of being in open places, crowds, public transport, and if severe patients may refuse to leave their homes. Yeah. So a fear of being outside. And agoraphobia is associated with panic disorder, and that makes sense, right? Panic disorder, they're afraid of additional panic attacks, so they have persistent fear of um, additional panic attacks and consequences of the panic attack. So they may refuse to leave home, and now they have become agoraphobic. Treatment is with CBT and SSRIs. Generalized anxiety disorder. This is excessive anxiety and worry about different aspects of daily life, work, school, children. For most days of for most days um, of 6 months or more. Um, Generalized anxiety disorder is associated with three or more of the following for adults: restlessness, irritability, sleep disturbance, fatigue, muscle tension, difficulty concentrating. Um, that's for adults. You need three of the following to be diagnosed with generalized anxiety disorder or GAD, um, which was restlessness, irritability, sleep disturbance, fatigue, muscle tension, difficulty concentrating. If it's a kid, you need one or more of the following: restlessness, irritability, sleep disturbance, fatigue, muscle tension, difficulty concentrating. Yeah. So that's what that is. So treatment is CBT, SSRIs, SNRIs, um, which are all first line, which means you give them first, and then buspirone, TCAs, and benzodiazepines are second line. Second line is given when first line doesn't work. So, yep. Let's see. And these symptoms need to be there for 6 or more months to be classified as GAD. Next, we have OCD, obsessive compulsive disorder. Obsessions, which are recurrent intrusive thoughts, feelings, or sensations that cause severe distress, relieved in part by compulsions, which are performance of repetitive, often time consuming actions, ego dystonic, is behavior inconsistent with one's beliefs and attitudes versus obsessive compulsive personality disorder, which is egocentric, associated with Tourette's syndrome. Treatment, like obsessive compulsive disorders associated with Tourette's syndrome, treatment is CBT and SSRIs. Clomipramine and venlafaxine are second line. Body dysmorphic disorder is a preoccupation with minor or imagined defects in appearance, causes significant emotional distress and repetitive appearance-related behaviors like mirror checking, excessive grooming, common in eating disorders like anorexia nervosa. Treatment is CBT. So basically, this is obsessions. OCD is when you have like someone is obsessed um, with doing. Okay, obsession is someone is obsessed with doing something repetitively. So the the reason they do the action over and over again is to relieve them of their distress. So the obsession is their thoughts. They have internal thoughts, um, feelings. Then they have to do something action-wise to relieve themselves of this thought. So someone could be thinking. Someone could be thinking about how the door is probably not locked. Even though that they know that they locked it, they'll go back and lock the door. And they'll go back and keep checking on the door. Like, they'll go back and keep checking on the locked door 3 times. So the thought is the fear of if the door is locked or not, and then the action is um, the compulsion, right? Action is the compulsion to go and check if the door is locked. So, and that makes them feel better. So the obsession is a recurring intrusive thoughts, feelings, or sensations that cause severe distress. It's relieved in part by compulsions. So it's relieved when they go and check the door. So what is the obsession? The obsession is did I lock the door? Did I lock the door? And what is a compulsion? Going to physically check if you lock the door. So it's compulsion, okay? So ego dystonic is when behavior is inconsistent with one's beliefs and attitudes. Versus obsessive compulsive personality disorder, which is ego syntonic. Ego dystonic, the behavior is not in line with one's beliefs and attitudes. So ego dystonic, it means when the thoughts that are wrong. So basically in OCD you have ego dystonic. Um, it's ego dystonic, which means that the thoughts that are wrong and unacceptable to the patient, like thoughts of harming someone, are there. So this is behavior inconsistent with one's beliefs and attitudes, right? And that's ego dystonic that's seen in OCD, and that goes against patients' own beliefs, like thoughts of harming somebody, thoughts that are like unacceptable, right? Now, this is different from what's seen in obsessive compulsive personality disorder, which is egosyntonic. Egosyntonic means uh, in someone with obsessive compulsive personality disorder has thoughts and feelings that feel natural to them. So Somebody with obsessive compulsive personality disorder have thoughts and feelings that feel normal and natural to them. The thoughts are not. The thoughts are acceptable. So yeah. Obsessive compulsive disorder is associated with Tourette syndrome. Treatment is CBT and SSRIs, uh, and clomipramine and venlafaxine are second line. Body dysmorphic disorder is a preoccupation with minor or imagined deficits in appearance. This causes significant emotional distress and repetitive appearance-related behaviors like mirror checking, excessive grooming, common in eating disorders like anorexia nervosa. Treatment is CBT. Next we have trichotillomania. This is compulsively pulling out one's hair. This causes significant distress and persists despite attempts to stop. Presents with areas of thinning hair or baldness or on any area of the body, most commonly the scalp. Incidence highest in childhood but spans all ages. Treatment is psychotherapy. So these patients, when they pull out their hair, they feel a little bit better. That's why they're pulling their hair out. So here we have a picture of a case of trichotillomania. You can see. So in alopecia, they'll be completely losing hair, like universally they'll be losing hair. But this is a case of trichotillomania because only certain parts are missing, and it's like an irregular pattern. See this? Um, it's quite evident she pulled out her hair, or he pulled out his hair. Okay. Adjustment disorder. Okay, so the, this is under adjustment disorder and PTSD. Post-traumatic stress disorder are both under trauma and stress-related disorders. Adjustment disorder is emotional or behavioral symptoms like anxiety outbursts that occur within 3 months of an identifiable psychosocial stressor like divorce or illness, lasting less than 6 months once the stressor has ended. If symptoms persist more than 6 months after the stressor ends, it is GAD. Symptoms do not meet criteria for major depressive disorder. Treatment CBT is first line, and antidepressants and anxiolytics may be considered. So what this means is the emotional outbursts that happened within 3 months of a tragic event. So there are emotional outbursts that happen within 3 months of a tragic event, like divorce or illness. But it but it lasts less than 6 months once the stressor goes away. If the outbursts still happen once the stressor goes away and it's over 6 months, it's now GAD, which is generalized anxiety disorder. And the symptoms cannot meet criteria for major depressive disorder. Remember, it cannot meet the criteria for SIGI caps. Okay, so what is this adjustment disorder? Adjustment disorder is something Like emotional outbursts happen within 3 months of a like of a tragic or unsettling event, right? Like the emotional outbursts have to happen within those 3 months of the tragic event. But it also has to be less than 6 months once the stressor went away to be classified as adjustment disorder. Okay, so that's what that is. I think this is like an easy diagnosis to miss, so remember this because I think I've found this to be hard to identify in the question stem. Adjustment disorder. Okay, PTSD. Question, sorry, post traumatic stress disorder is when you experience or you discover that a loved one experiencing or discovering that a loved one has experienced a life-threatening situation like a serious injury, rape, witnessing death, and there is persistent hyperarousal and avoidance of associated stimuli, intrusive, intrusive re-experiencing of the event, nightmares, flashbacks, changes in cognition or mood. Uh, you see fear, horror, distress. Having PTSD is hard. Okay, that's an acronym. A disturbance lasts more than 1 month with significant distress or impaired functioning. Treatment is cognitive behavioral therapy, SSRIs, and venlafaxine are first line. Prazosin can reduce nightmares. Acute stress disorder lasts between 3 days and 1 month. Treatment is CBT and pharmacotherapy. Uh, okay, so treatment is CBT. Pharmacotherapy is usually not indicated. So, what is PTSD? So, this is when someone like re-experiences a trauma. So PTSD, experiencing or discovering that a loved one has experienced a life-threatening situation, like serious injury, rape, witnessing death. Okay, so it's when you're reliving events of a traumatic situation, right? It could be you, or it could be you that had a traumatic incident, and you're reliving that. Like you got into a car crash, and now you won't get into a car because you have flashbacks of that car accident, right? Now, when you say experience or discovering that a loved one has experienced a life-threatening situation, serious injury, rape, witnessing death. I'm not sure why first aid wrote it like that, but maybe they're saying that's like the patient experienced someone that they loved die, and then um, now they have PTSD from their flashbacks of of seeing them die. So they're not able to sleep properly. Okay, so now that person is experiencing hyperarousal. Um, they're vigilant, hypervigilance. Okay, and they avoid, if it's a car crash, they avoid cars. If that person if they got into a car accident, they avoid the car. If the patient saw someone uh, they love die drowning, they avoid going near water, and they avoid going on boats, things like that. So this is what avoidance of associated stimuli is: intrusive re-experiencing of the event. Yeah, they have flashbacks to the event, and this could present as this could come in dreams like nightmares, or they could actually be just awake, and their mind will go back to the actual incident of the trauma, and they'll actually see a picture of the trauma. That's a flashback. It's not a hallucination, it's a flashback. Their mind just goes back to the incident and it's very vivid. So it's like they're seeing it in there right before their eyes. Okay, so the changes in cognition or mood, like fear. So this patient will have fear, horror, distress. Um, the disturbance lasts more than 1 month with significant distress and impaired functioning. So they can't maintain daily life due to these flashbacks. Okay, treatment is cognitive behavioral therapy, SSRIs, and venlafaxine, which are all first line. Uh, Prazosin can reduce the nightmares. Remember that. Acute stress disorder. Um, I think of acute stress disorder baby, like baby PTSD. This has all the symptoms of PTSD, except that acute stress disorder lasts between 3 days and 1 month. The treatment is cognitive behavioral therapy. Okay, and psychotherapy is not indicated for acute stress disorder. Now, this chart down here talk, uh, talks about the different timelines of all the disorders we discussed. So you can go through that, right? We discussed all of them, okay? So in detail, this is literally talking about a timeline, which is probably one of the most important um, things in psychiatry to make a diagnosis. Okay, so timelines are very important. Okay, personality disorders. So personality disorder, you need to be 18 to be diagnosed with a personality disorder. Um, okay, so personality trait. What is that? It's an enduring, repetitive pattern of perceiving, relating to, and thinking about the environment and oneself. That's just the way that somebody is. Personality trait. An enduring, repetitive pattern of perceiving, relating to, and thinking about the environment and oneself. Yeah, just like the trait you have. So, if somebody is arrogant, that's a personality trait. Somebody's impulsive, that's also a personality trait. Okay? Now, personality disorder, what is that? Personality disorder, an inflexible, maladaptive, and rigidly pervasive pattern of behavior causing subjective distress and or impaired functioning. Person is usually not aware of the problem. Egosyntonic. What is egosyntonic? Yeah, that's what you see in obsessive personality, um, obsessive compulsive personality disorder, egosyntonic. So basically, um, your thoughts are acceptable. You believe your thoughts are acceptable. Patient believes thoughts are acceptable and normal. So patient believes thoughts are acceptable and normal only to them, right? But then in reality, it's only to them. It's not normal, right? In somebody with a personality disorder. But okay, we're gonna get into that. Usually presents by early adulthood. Okay, so you have to be over 18 or over to be diagnosed with a personality disorder. There's three clusters: type A, type B, and type C. So first aid classifies as weird, wild, and worried based on the symptoms. Okay. So personality disorder is like, when somebody has a disorder, um, like somebody has a type of personality that impairs with their daily functioning, and they believe their thoughts are acceptable, which is egosyntonic, but they're not. Okay, cluster A. Cluster A is odd or eccentric. There is an inability to develop meaningful social relationships, no psychosis, genetic, no psychosis. There is a genetic association with schizophrenia. Okay. Okay. So these type A, um, they're eccentric. They don't have meaningful social relationships. They can't really socialize with people. There is no psychosis, so there is no delusions or hallucinations. However, there is a genetic association with schizophrenia. Okay, so the first one is paranoid. There's a pervasive distrust, yeah, accusatory. So they accuse paranoid people with paranoid personality disorder accuse people of things. Um, Paranoid personality. They're suspicious, hypervigilant, and have a profoundly cynical view of the world. So cynical is when you believe that people are motivated purely by self-interest, distrustful of human sincerity and integrity. So it's like a negative view of the world where you think everybody is selfish. Um, and nobody wants to do anything out of the goodness of their hearts. Basically, everyone has ulterior motive. That's what cynical means. Yeah. Okay. So paranoid. Okay, pervasive distrust. They're just like not. They don't trust people. That's what that is. And they usually accuse people of things that they shouldn't be accused of. So suspicious, hypervigilant, and profoundly cynical view of the world. Schizoid. Okay, schizoid personality is a voluntary social withdrawal, aloof. They're usually aloof. There's limited emotional expression, content with social isolation versus avoidant. So these type of patients, they live by themselves. They're happy in solace. They like to be alone. In fact, being with people it makes them wary. They like to be by themselves. Um, they have limited expression on their face, and they want to be alone. Where versus avoidant personality disorder, where the avoidant personality disorder wants to be with people, but they lack the social confidence to go up to people and be in a social setting. We're gonna get into that. Okay. So next we have schizotypal. Um, Schizotypal is they usually have an eccentric appearance, which means they probably have bright colored clothes on. Um, they believe that they can control the sun if they wear a yellow shirt. That's an example. Um, they they take they listen to the body if they want to take medications, things like that. It's like a it's like a magical type of thinking. Yeah, okay. So odd beliefs are magical thinking right here. Odd beliefs are magical thinking. They have interpersonal awkwardness. They don't do well in social situations either. They're not able to read rooms. Um, they can't read they cannot read between the lines. Yeah. So this is included in the schizophrenia spectrum, but of course it is not schizophrenia, but it is on the spectrum. Cluster B, personality disorders. Okay, so this is the one where the first aid classifies as wild. Cluster A was the weird one. Cluster B was the wild one. So let's see, cluster B. There is a cluster B is dramatic, emotional, or erratic. There's a genetic association with mood disorders and substance abuse. What are mood disorders? Major depressive disorder and bipolar disorder. Cyclothymia, dysthymia. These are all mood disorders. Okay. So okay. So cluster B personality disorders. Antisocial. There's a disregard for the rights of others, with lack of remorse. Antisocial involves criminality, impulsivity, hostility, and manipulation. Males have a greater rate of antisocial personality disorder than females. Must be 18 or over. Must be 18 years of age or over, with evidence of conduct disorder with onset. Must be 18 or older with evidence of conduct disorder onset before age 15. Okay, so basically, to be diagnosed with antisocial personality disorder, there needs to be evidence of conduct disorder before the age of 15. And then only can you get a diagnosis of antisocial personality disorder. Diagnosis is conduct disorder if less than 18 years old. So until 18, you would have conduct disorder if you are if you have a criminal record, if you're impulsive, hostile, and you manipulate people, if you have aggression towards animals, um, and you don't care about the rights of others, and you don't feel bad about it. So this would be conduct disorder until 17 years old, and then it turns into antisocial personality disorder by the time of 18, by the time of age 18. So antisocial personality disorder is what people commonly call psychopathy. Okay. Next we have a borderline personality disorder. This is unstable mood and interpersonal relationships. There's a fear of abandonment, impulsivity, self-mutilation, suicidality, sense of emotional emptiness. Females have a greater risk of borderline personality disorder than males. Splitting is a major defense mechanism. Remember we talked about splitting? Everything is either all good or all bad. There is no gray area. I think I gave the example of a doctor being late to an appointment, and the patient, she's like, oh my gosh, the doctor does not care about me. Like he's just he's just a mean person. He's a jerk. He doesn't care about me. He obviously has other priorities. When the doctor comes and he explains, I'm so sorry, I was stuck in traffic. But the patient is like, nope, does not care about me. This is an example of splitting. But previously she was like, she had a great relationship with the doctor, and everything was good. They had a really good doctor-patient relationship, and she had no complaints before, but then suddenly he becomes all bad because he was late to her appointment. Okay, so that is a case of splitting. It is seen in borderline personality disorder. Histrionic. This is attention seeking. So this is when someone is attention seeking. There's dramatic speech and emotional expression, shallow and label emotions, sexually provocative, may use physical appearance to draw attention. Okay, so histrionic personality is like they seek attention, um, usually by dressing provocatively. They put a lot of work into their appearance because they want to garner attention and use their looks to get what they want. Um, Dramatic speech and emotional expression. They're shallow. They have labile emotion, so they're very emotional. They go from angry to sad, um, to happy to excited really fast. Um, if you just Google histrionic personality, pictures of women, like pictures of women with a lot of makeup come on. Um, they're dressed pretty revealing, things like that. Okay, that's histrionic personality disorder. Next, we have narcissistic personality disorder. This is when somebody is grandiose. They have a sense of entitlement, lacks empathy, and requires excessive admiration. Um, these patients often demand the best and react to criticism with rage or defensiveness. Fragile self esteem. The reason why they want the best and they react to criticism with rage is because they have a very low self esteem and they're trying to make it up. They're trying to make it up for it by being grandiose. They're often envious of others. Okay, so the thing to remember about the thing to remember about narcissistic personality disorders is that these patients, they have a very low self-esteem, so they try to compensate by being grandiose, um, and have that sense of entitlement, and they always need um, admiration, telling them, people telling them how good they are. Yeah, and this is different from actual grandiosity in bipolar disease. Bipolar disease, they actually believe they are the best. They have like thoughts of like, oh, they came to save the world, and they have thoughts of, they're the CEO of a multi billion dollar company. These are delusions that they actually believe. But in narcissistic personality disorder, it's a compensation. It's like they believe that they deserve the best, but as a compensation to make other people to make other people believe that they are better than they are. But in actuality, they think very lowly of themselves. Right? Okay. Okay. Now we have cluster C personality. This first aid called them like the worried group. Here, this one is anxious or fearful. Anxious or fearful. There's a genetic association with anxiety disorders. Avoidant personality disorder. They're hypersensitive to rejection and criticism. Socially inhibited. timid, feelings of inadequacy, desires relationships with others, versus schizoid. Okay, so basically, um, avoidant is when somebody's hypersensitive to rejection and criticism. They can't form social circles, even though they crave social circles. They crave that wanting to belong and going up to people, talking to them, but they can't. They're socially not. They're socially inept. Um, they're worried. They feel like they're not good enough, but they do crave relationships. Versus schizoid. Schizoid does not crave relationships. They like to be alone. In fact, being in a social circle makes them upset. They don't like to. They don't want to be there. Next, we have obsessive compulsive personality disorder. This is a preoccupation with order, perfectionism, and control. Egocentric behavior. Okay, behavior consistent with one's own beliefs and attitudes versus OCD. Okay, so this is a preoccupation with order, cleanliness, perfectionism, control. Um, I mean, yeah, order. Like everything about them has to be perfect. Everything has to be in a row. Like it has to be just perfect. Even in their personality, they can't. They can't stutter. Everything is tip top. With these patients. Well, this is obsessive compulsive personality disorder. So ego syntonic. So everything that um, they do is in alignment with their own beliefs. Like they believe that everything. They believe that if they're leading a project, um, yeah, if they're leading a project, they believe that everything. Like if they have a team of 5 people, um, the leader with this obsessive compulsive personality disorder believes that everything should be done his way, and it cannot be done any other way. Otherwise, if it's done some other way, it's wrong. So he's like how somebody might call him a control freak, because he wants everything done exactly how he dictates. So this is a preoccupation with order, perfectionism, and control, and he actually believes that that is the right way to be, and he's not doing any wrong. Behavior consistent with one's own beliefs, right, and attitudes. And this is different from OCD because that is ego dystonic, where OCD people have behavior that is that behavior thoughts that is actually unacceptable to them. Okay. Dependent personality disorder. There's excessive need for support. They have low self-confidence. Uh, Patients often get stuck in abusive relationships. So these patients can be seen as submissive and clingy. Okay. Dependent personality is like when they're stuck with someone, they're very dependent. Like they make their entire world somebody else, so they don't know how to function on their own if that person were to be removed from the situation. They need to be taken care of. Like people who have dependent personality disorder need to be taken care of. Um, yeah. So in malingering, the symptoms are intentional, motivation is intentional, the patient consciously fakes, profoundly exaggerates, or claims to have a disorder in order to attain a specific external gain, like avoiding work, obtaining compensation, getting disability. There is poor compliance with treatment or follow-up of diagnostic tests. Complaints cease after they get what they want versus factitious disorder, which we're going to talk about next. So malingering, it's like you're faking your symptoms uh, for uh, for financial gain. Maybe you need to be put on disability, so you lie to the doctors and say you actually have pain when you don't. Um, you can't so you can't go to work. So if you're disabled, they will have to write that you're disabled. So this is malingering, and some symptoms of this would be exaggerating symptoms, um, trying to get the doctor to write that they can't go to work, that they need to be compensated. Um, they do not. The patients in who malinger, they don't follow up with treatment or diagnostic tests. Um, they like the complaints and symptoms stop after they get what they want. Okay, next, infectious disorder. Infectious disorder. Symptoms are intentional. Motivation is unconscious. So symptoms are intentional. Motivation is unconscious. So malingering, you're actually faking it. You know you're faking it. Factitious disorder. The symptoms, you hurt yourself on purpose, but the motivation is unconscious. Patient consciously creates a physical and or psychological symptoms in order to assume the sick role and get medical attention and sympathy. It's for an internal gain. So factitious disorder imposed on self, formerly called Munchausen syndrome. This is a chronic factitious disorder with predominantly physical signs and symptoms, characterized by history of multiple hospital admissions and willingness to undergo invasive procedures, more common in women and healthcare workers. Okay, so factitious disorder imposed on another. This was called Munchausen syndrome by proxy. Illness in a child or elderly patient is caused or fabricated by the caregiver. Motivation is to assume a sick role by proxy. This is a form of child or elder abuse. Okay, so factitious disorder, the symptoms are intentional, motivation is unconscious. So what it means is like, let's see, motivation is unconscious. So when we say motivation is unconscious in factitious disorders, it means the patient has hidden desires and drives that the patient is unaware of. So their symptoms, they do it to themselves. They actually cut themselves, they make themselves sick. They take medication, but the reason why they're doing it, they don't know. They have drives that motivate them that they don't know. Um, they don't know the reason for. So that is factitious disorder. So symptoms are intentional, motivation is unconscious. Patient consciously creates physical and or psychological symptoms in order to assume the sick role and to get medical attention and sympathy, which is the primary gain. It is sympathy. They want sympathy. Okay. Now, factitious disorder imposed on self. This was called Munchausen before. This is a chronic disorder. Um, with predominantly physical signs and symptoms, right? Because they are hurting themselves for sympathy. Characterized by history of multiple hospital admissions and willingness to undergo multiple invasive procedures, more common in women and healthcare workers because they have access to what medications. They have access to medications, the syringe, medical tools, so they're able to, you know, if you have access to something, you're more likely, you can be more likely to do it. Now, okay, so that's why factitious disorder imposed on self, it is more common in women and healthcare workers, and the primary goal is sympathy. Affective disorder imposed on another. So this is used to be called Munchausen's syndrome by proxy. This is illness in a child or elderly patient. Illness in a child or elderly patient is caused or fabricated by the caregiver. Motivation is to assume a sick role by proxy. This is a type of child and elder abuse. So, illness in a child or older patient is caused by the caregiver, and they intentionally the caregiver intentionally makes the child or older person sick. Who is the most vulnerable? Children and elderly. Okay, so motivation is to assume a sick role by proxy. Yeah, so this is still sympathy. The primary goal is sympathy from other people for having a sick child. Okay, making a note. Oh yeah, somatic symptom and related disorders. Symptoms are unconscious. Motivation is unconscious. So their symptoms are unconscious and motivation is unconscious. Category of disorders characterized by physical symptoms causing significant distress and impairment. Symptoms not intentionally produced or feigned. Somatic symptom disorder, one or more bodily complaints like abdominal pain, fatigue, lasting months to years. Somatic symptom disorder is associated with excessive, persistent thoughts and about somatic symptom disorder is associated with excessive, persistent thoughts and anxiety about symptoms. May co-occur with medical illness, treatment, regular office visits with the same physician in combination with psychotherapy. Conversion disorder, also called functional neurologic symptom disorder, there is a loss of sensory or motor function like paralysis, blindness, and mutism, often following an acute stressor. Patient may be aware of a patient may be aware of but indifferent towards symptoms, which is known as labile indifference. This is more common in females, adolescents, and young adults. Illness anxiety disorder is a preoccupation with acquiring or having a serious illness, often despite medical evaluation and reassurance. Minimal to no somatic symptoms. Okay, so somatic symptoms. What is this? The symptoms are unconscious. Motivation is unconscious. So, um, the symptoms happen to them. They don't know. They have nothing to do with the symptoms that they're getting. They actually feel these symptoms. So again, right, the patient doesn't know how they got these symptoms. Doesn't know. Patient doesn't know how they got these physical symptoms. So symptoms are unconscious. Motivation is unconscious. So there is no hidden drive. Category of disorders characterized by physical symptoms causing significant distress and impairment. Okay. Symptoms not intentionally produced or feigned. So they don't make their own symptoms. They happen to them. Somatic symptom disorder, one or more body complaints like abdominal pain, fatigue, lasting months to years, associated with excessive, persistent thoughts and anxiety about symptoms. So th- these patients in somatic symptom disorder, they get physical pain from extreme anxiety. So patient has physical pain from extreme anxiety. Okay. This may co-occur with medical illness. Treatment is regular office visits with the same doctor in combination with psychotherapy. So you do not refer them. They need to be reassured. So you um, you have them keep coming back. Conversion disorder, also called functional neurologic syndrome disorder. There is loss of sensory or motor function, like paralysis, blindness, mutism, often following an acute stressor. So somebody may have, like, they heard some tragic news, and suddenly they have paralysis. They can't see. They can't talk. This is conversion disorder. I think of this as one converts to something else. Somebody was seemingly normal, it converts to something abnormal after hearing the bad news. I'm writing patient gets bad news. Patient gets bad news and can't see anymore. Can't see anymore. With an example, okay? Patient may be aware but indifferent towards symptoms. Label indifference. Label indifference. It's a term used to describe a patient's apparent lack of concern or distress about their significant physical symptoms. Yeah. So label indifference. Patient knows that they have something wrong with them, but they're indifferent to their symptoms. Illness anxiety disorder is a preoccupation with acquiring or having a serious illness, often despite medical evaluation and reassurance. There are no somatic symptoms, or very little. So, illness anxiety disorder means they actually believe they have cancer or some life threatening disease, despite being told they don't. They believe that they're constantly sick. So everyone believes that they have cancer despite all tests coming back negative. Next, we have anorexia nervosa. Okay, so anorexia nervosa. Um, okay, so these are all eating disorders. So we're gonna go through anorexia nervosa, bulimia nervosa, binge eating disorder, and pica. They are all eating disorders, and they are more common in young women. The first one is anorexia nervosa. This is intense fear of weight gain, over evaluation of thinness, and body image distortion, leading to calorie restriction and severe weight loss, resulting in inappropriately low body weight. Um, there are three types. No, there are two types. There are two types of anorexia nervosa: binge eating, purging type. This is recurring purging behaviors. For example, these patients take laxative or abuse diuretics and have self-induced vomiting or binge eating over the last 3 months. The other type is restricting type. Uh, there's primary disordered. There's primary disordered behaviors. Primary. There's primary disordered behaviors. The primary disordered behaviors include dieting, fasting, and/or over-exercising. No recurring purging behaviors or binge eating over the last 3 months. Okay. Brief feeding syndrome often occurs in significantly malnourished patients with sudden increased calorie intake. This leads to increased insulin, which would decrease phosphate, potassium, and magnesium, and this would lead to cardiac complications, rhabdomyolysis, and seizures. Treatment is psychotherapy, nutritional rehabilitation, and antidepressants. Okay, so we're going to go through this. What is anorexia nervosa? It is an intense fear of weight gain. They're obsessed with thinness, um, body image distortion. Yeah, so there is body image distortion leading to calorie restriction and severe weight loss, resulting in very low body weight. So these individuals, uh, they don't want to gain weight. They have a distorted image of their body, and that leads them to calorie restrict. It leads them to be afraid of eating, so they restrict a lot of food. Um, causes very severe weight loss and low BMI. Um, and this causes a BMI. Uh, of 17.5 or lower. That is so there's a range. 17.5, that's anorexic. So anything under 18.5 would be considered anorexic. Okay, one sec. Yeah, so BMI under 18.5 would be considered anorexic. Okay. Um, so binge eating purging type. Um, so this is purging, like recurring purging behaviors, laxative, laxative or diuretic use, self-induced vomiting, or binge eating over the last 3 months. So these patients, they eat and then they vomit. They stick their hands in their throat and vomit all the food that they ate. Um, binge eating purging type. Okay, so recurring purging means um, self-induced vomiting or taking laxatives to poop out everything you ate, or abusing diuretics to pee out everything you drank. So these are all like very self-damaging behaviors. Um, okay, so that's one part of binge eating and purging. The second part would be binge eating over the last 3 months. So, anorexia nervosa is an intense fear awakening of over-evaluation of fitness and body image distortion, leading to calorie restriction and severe weight loss, resulting in inappropriate low body weight. The first one is binge eating, purging type. Here we have recurring purging behaviors by using laxative or diuretic abuse. And you also have self-induced vomiting or binge eating over the last 3 months. And restricting type is the primary disordered behaviors, including dieting, fasting, and or overexercising. No recurring purging behaviors or binge eating over the last 3 months. Refeeding syndrome often occurs in significantly malnourished patients with sudden increased calorie intake. This leads to an increase in insulin, and increased insulin will lead to decreased phosphate, decreased potassium, and decreased magnesium, and this will cause cardiac complications and rhabdomyolysis and seizures. The treatment is psychotherapy, nutritional rehabilitation, and antidepressants. Okay, so what this anorexia is when somebody has a BMI of under 18.5. They have an fear of being fat, so they avoid food. There are two types in which individuals do this. The first one is binge eating, purging type. Purging means what? Um, this one is where a patient has episodes of binge eating followed by purging. Purging means vomiting and abusing laxatives and diuretics to pee and poo all your food out, and vomiting to get your food out. So this is they eat quite a bit of food, then they try to get rid of it. So that's binge eating and purging. Okay, and this will last 3 months. Last 3 months. Okay, so they have a condition. Um, they have history of binge eating and purging over 3 months, and they have a BMI under 18.5. They have anorexia nervosa, binge eating, purging type. Now, next one, restricting type. This is the one where they just avoid food. They don't like to eat, and they overexercise. So there is no history of eating excess amounts of food and trying to get rid of it here. No, so it says no recurrent purging behaviors or binge eating over the last 3 months. So this would be anorexia nervosa restricting type. So somebody has a BMI of under 18.5 and they have been fasting and over exercising, and this has lasted at least 3 months. They have anorexia nervosa restricting type. And they cannot have purged or binge ate over like in the last 3 months, okay, to have the restricting type. Now, refeeding syndrome, this happens when you introduce a lot of food to somebody who has not eaten in a long time. So refeeding syndrome is seen in anorexics, where if you suddenly give them food, they have, because you give them a lot of food, this will also spike your insulin, and when you spike your insulin, it will decrease your phosphate because insulin causes phosphate to move from the blood into the cell. So the phosphate is moving out of the blood, which will give you hypophosphatemia, and it will also give you hypokalemia and hypomagnesemia, which will lead to cardiac issues and rhabdomyolysis and seizures, because you have electrolyte imbalance now, so you get seizures. The treatment is psychotherapy and nutritional rehabilitation and antidepressants. Next we have bulimia. Bulimia is recurring episodes of binge eating with compensatory purging behaviors at least weekly over the last 3 months. A BMI often normal or slightly overweight, which is different from anorexia. Anorexia, you have a BMI under 18.5. In bulimia, you will have 18.5, or you'll be a little bit overweight, over the recommended BMI in bulimia. Bulimia is associated with parotid gland hypertrophy. You will see increase in amylase. Here, you will see enamel erosion, Mallory-Weiss syndrome, electrolyte disturbances like decrease in potassium, decrease in chloride. You will see metabolic alkalosis because they're vomiting. They're vomiting out food, so that vomiting results in metabolic alkalosis. And you will see dorsal hand calluses from induced vomiting. Muscle sign. Okay, so parotid gland hypertrophy. What is parotid gland? So this is parotid gland hypertrophy right here. You see this? This part will be enlarged, the parotid gland, in bulimics. Okay, now increase in amylase. Remember amylase. Enamel erosion. You will also see enamel erosion. So this is the erosion. See this right here? Okay. Maybe this is a better picture. If you can see the enamel being eroded away, disintegrating. This is probably the best picture to see. Oops. All this is eroded. Right. Okay. Alright. Now we have Mallory-Weiss syndrome. Why would somebody have Mallory-Weiss syndrome in bulimia? So, Mallory-Weiss syndrome is caused by tears in the mucosa at the junction of the esophagus and stomach, usually due to severe vomiting or retching. Bulimia can lead to Mallory-Weiss syndrome because of frequent vomiting. Bulimia often involves repeated self-induced vomiting, which increases intra-abdominal pressure and causes strain on the esophageal lining. Forceful retching causes the Mallory-Weiss syndrome. So the forceful nature of vomiting can lead to mucosal tears, especially if the vomiting episodes are prolonged or violent. Okay, so that's why bulimics would get Mallory-Weiss syndrome. Okay, so the self-induced vomiting. So the self-induced vomiting causes. Okay, self-induced vomiting increases intra. Okay, so the reason bulimics get Mallory-Weiss syndrome is because there's increased vomiting, which increases the intra-abdominal pressure and causes strain on the esophageal lining, causing tears in your esophagus. Okay. Um, you have electrolyte imbalances in bulimia because of vomiting, and you'll see low potassium and low chloride, and you will see metabolic alkalosis because that is the alkalosis you get from vomiting. You'll see dorsal hand calluses from the vomiting because they stick their hands into their mouths to induce vomiting. So this is Russell sign right here. Russell sign. So this is Russell sign right here. See this? So it's like these calluses on your knuckles right here that you get from sticking your hand in your mouth to induce the vomiting. Okay, treatment psychotherapy, nutritional rehabilitation, antidepressants. Bupropion is contraindicated in bulimia due to seizure risk. Binge eating disorder. Binge eating disorder is recurring episodes of binge eating without purging behaviors at least weekly over the last 3 months. There is increased diabetes risk, most common eating disorder in the adults. Treatment is psychotherapy, which is first line. The SSRI given here is lisdexamfetamine. So, binge eating disorder. This is when uh, people overeat, um, and they don't vomit after the excess eating. This is binge eating disorder. They eat large amounts of food, um, and it has to be present at least 3 months for it to be classified as binge eating disorder. You have increased risk for diabetes. It is the most common eating disorder in adults. Next, we have pica. Pica is um, recurring episodes of eating non-food substances like dirt, hair, paint chips over the last 1 month or more that are not culturally or developmentally recognized as normal may provide temporary emotional relief. Pica is common in children and during pregnancy. And pica is associated with malnutrition, iron deficiency, anemia, developmental disabilities, and emotional trauma. Treatment is psychotherapy and nutritional rehabilitation. SSRIs are second line. Um, nutritional rehab is first line. Gender dysphoria. Gender dysphoria is significant incongruence between one's experienced gender and the gender assigned at birth, lasting over 6 months and leading to persistent distress. Individuals may self-identify as another gender, pursue surgery or hormone treatment to rid self of primary and secondary sex characteristics, and or live as another gender. Gender nonconformity itself is not a mental disorder. Okay, so transgender is when someone desires and often makes lifestyle changes to live as a different gender. Medical interventions such as hormone therapy, sex reassignment surgery may be utilized during the transition to enable the individual's appearance to match their gender identity. Transvestism um, is when a person derives pleasure from wearing clothes like a vest of the opposite sex, like cross dressing. Um, Transvestic disorder is transvestism that causes significant distress, functional impairment. It is a paraphilia, psychosexual disorder, not part of gender dysphoria. Okay, so gender dysphoria is when, like, for example, a boy that is born with a penis feels that he is actually supposed to be a girl. Um, so gender assigned at birth. Yeah. Um, let's say he was born with a penis, but then he feels like he should be a woman. So so he gets surgery or hormone treatment to get rid of his um, genitalia, like to change his penis into a vagina, um, and get hormone therapy to get rid of beard, um, and actually undergo sex reassignment surgery to become a woman. Um, Gender nonconformity itself is not a mental disorder. Okay, yeah. So gender, even if you don't conform to traditional gender roles, that's not a mental disorder. Okay, so yes, transgender is when a man undergoes sex reassignment surgery to become a woman, and a woman undergoes sex reassignment surgery to become a man. Um, so they change themselves physically to match what they believe they are. Transvestism is when, like for example, a man dresses like a woman, or a woman dresses like a man. Transvestic disorder, it causes significant distress, function impairment. It is a paraphilia, psychosexual disorder, not part of gender dysphoria. So paraphilia is an intense and persistent sexual interest that deviates from what is typically considered socially or culturally acceptable. It's I guess that could be like a fetish. Paraphilia was like a fetish. It's something that sexually turns somebody on. So yeah, transvestic. So cross-dressing can be a paraphilia, then. Okay, so cross-dressing itself is not a paraphilia. So cross-dressing itself is not a fetish. However, transvestic disorder is a type of paraphilia that involves intense sexual arousal from cross-dressing, leading to significant distress or impairment of daily life. Okay, so cross-dressing itself is not a fetish, but transvestic disorder is a type of paraphilia that involves intense sexual arousal from cross-dressing. Okay. I'm gonna make a note of this. I did not know this. And this transvestic disorder causes impairment in your daily life. Sexual dysfunction includes uh, sexual desire disorders like hypoactive sexual desire or sexual aversion, sexual arousal disorders like erectile dysfunction, orgasmic disorders like anorgasmia, premature ejaculation, sexual pain disorders like dyspareunia and vaginismus. The differential diagnosis includes penis. Okay, so penis is the acronym. The P stands for psychological. If nighttime erections still occur. E, endocrine. Diabetes, low testosterone could be the reason for sexual dysfunction. Neurogenic, like post-operative spinal cord injury, can cause sexual dysfunction. Insufficient blood flow, like atherosclerosis, can cause sexual dysfunction. Substances like antihypertensives and antidepressants and ethanol will decrease sex drive. So first aid doesn't go into detail. Guess it is. I guess that's all we need to know. Okay, so sleep terror disorder. What is that? Sleep terror disorder. Sleep terror disorder, periods of inconsolable terror with screaming in the middle of the night, most common in children, occurs during slow wave, um, deep, deep stage, which is also known as stage N3, non-REM sleep, with no memory of the arousal episode, as opposed to nightmares that occur during REM sleep. In REM, you remember the dream. Triggers for sleep terror disorder include emotional stress, fever, and lack of sleep, usually self-limited. So this is sleep terror disorder is when you have no memory of waking up. So kids here, usually it happens in children, um, they wake up screaming in the middle of the night, but they have no memory of waking up. Okay. Making note of this, children. Okay. So real children wake up screaming in the middle of the night, but have no memory of waking up during the night screaming. Um, this sleep terror disorder happens during the slow wave slash deep non-REM sleep, which is also known as stage N3. And sleep terror disorder is different from REM sleep. Is different from nightmares that happen during REM sleep because children remember those nightmares. Okay, enuresis. Enuresis is nighttime urinary incontinence for 2 or more weeks. Shit. Nighttime urinary incontinence. Okay, so enuresis is a nighttime urinary incontinence for um, it's a nighttime urinary incontinence um, more than 2 times a week, or 2 times for 3 months or more in person over 5 years old. First sign treatment is behavior modification, like schedule avoids nighttime fluid restriction and positive reinforcement. Refractory cases, bedwetting, alarm, oral desmopressin, which is a ADH analog, and desmopressin is preferred over imipramine due to fewer side effects. So Enuresis in somebody over 5 years old, if they wet the bed, if they wet the bed 2 times or more in a week for at least 3 months, they have something known as enuresis. Um, the first thing you want to do is behavior modification. So you time when they urinate, mm, to avoid bedwetting, and then you restrict giving so much fluid at night so they don't wet the bed. And positive reinforcement. For cases that don't get solved with schedule voids and nighttime fluid restriction, you can set a bedwetting alarm, and you can also give desmopressin, which is an ADH analog, and ADH is what holds water back in the collecting tubules of your kidneys, so that will help with the enuresis. And ADH, desmopressin, is preferred over imipramine to lower side effects. Narcolepsy. This is excessive daytime sleepiness despite awakening well rested, with recurrent episodes at rapid onset. Um, Overwhelming sleepiness 3 times or more per week for the last 3 months. Narcolepsy is due to decreased orexin, also known as hypocretin, production in the lateral hypothalamus, and dysregulated sleep-wake cycles. Narcolepsy is associated with hypnagogic uh, hallucinations, and hypnagogic hallucinations are hallucinations you see just before going to bed. And hypnopompic hallucinations are also seen just before awakening. So narcolepsy is associated with hypnagogic and hypnopompic hallucinations. In hypnopompic hallucinations is what you see right before awakening from your sleep. Now, nocturnal and narcoleptic sleep episodes that start with REM sleep. Nocturnal and narcoleptic sleep episodes that will start with REM sleep. So narcolepsy has nocturnal and narcoleptic sleep episodes that start with REM sleep, right? So we know the normal stages of sleep. What are they? Stages of sleep. So in narcolepsy, you have narcoleptic sleep episodes that start with REM sleep, but in reality, REM sleep is all the way at the bottom, right? It's near the last stage of sleep. So in narcolepsy, you fall directly into REM sleep. These are the first stage. This is the first stage. So you're awake, then you have stage 1, then stage 2, then stage 3. also known as stage 1 is also known as N1, where you drift off to sleep. And then you have N2, which is a deeper sleep, and there's a decrease in heart rate. Then you have N3, which is deep sleep, and this is important for memory consolidation. Remember that N3 is important for memory consolidation. Then you go into REM sleep, and REM sleep is where you have vivid dreams and there is muscle paralysis, except for breathing. Yeah, so REM sleep is like your happy sleep. But then, like people who don't have narcolepsy, we get to REM sleep in stages. After stage 1, stage 2, stage 3, then REM sleep. But in narcolepsy, you directly fall into REM sleep. Making a note. Okay. Um, Next you have um, cataplexy. Okay, so next you have cataplexy, which is loss of all muscle tone following strong emotional stimulus such as laughter. So here, somebody with narcolepsy, you go limp after you had a laughing attack. Okay, so um, that's narcolepsy with cataplexy. Um, there's also narcolepsy without cataplexy. So narcolepsy without cataplexy is a type of narcolepsy characterized by excessive daytime sleepiness, but without the sudden loss of muscle tone, which is known as cataplexy. And cataplexy, it's present in other types of narcolepsy. So what I'm trying to say is that cataplexy is not a criteria to have narcolepsy. Okay, so yeah, treatment for narcolepsy is good sleep hygiene, scheduled naps, regular sleep schedule, daytime stimulants like amphetamine and modafinil, and/or nighttime sodium oxybate. Substance use disorder. This is a maladaptive pattern of substance use involving two or more of the following in the past year. The first one is tolerance, then we have withdrawal, then intense, distracting cravings, then using more or longer than intended, using the substance more or longer than intended. Then we have persistent desire, but inability to cut down on the substance. Then we have time consuming substance acquisition, use, or recovery, which means you spend a lot of time getting the drugs. Next, you have impaired functioning at work, school, or home, uh, or social or interpersonal conflicts, or reduced recreational activities. Um, Over one episode of use involving danger, like unsafe sex, driving while impaired, or continued use of the substance despite awareness of harm. So if you have two or more of any of these criteria in the list over the past year, you have someone that has substance use disorder. Next, we have stages of change and overcoming addiction. I remember this as PCP AMR. PCP AMR. Okay, so P stands for pre-contemplation, which is when you deny that you have a problem. Then you have contemplation, where you acknowledge the problem but are unwilling to change. Then you have preparation and determination, which is preparing for behavioral changes. 4 is action and willpower, changing the behavior. You're actually changing the behavior. Number 5 is maintenance. You maintain the changes. 6 is relapse, if applicable, returning to old ways and abandoning your changes. So what did I say? PCP, AMR. PCP, AMR. So you think about PCP as your primary care physician, where if your BMI is over 30, they'll tell you, like doctors will tell you, like your primary care doctor will tell you that you need to work out. Um, he may refer you to a dietitian. So think of I kind of associate with that because it's easier, like for to associate when you make up stories in your head. So a doctor might be the first person that will tell you that you need to make a lifestyle change for your health, right? So once your labs come back, your BCP tells you that you, PCP's primary care physician tells you that you need to lose weight and make a lifestyle change. Otherwise, you can, if you're pre-diabetic, you can get diabetes. So PCP and then AMR. I don't know. I just remember AMR because EMR is like, I think EMR is like um, the system that doctors use. I think it's called EMR. So let's see. Let's see what EMR is. Okay, electronic medical record, digital version of patient's medical history. Okay, so then, right. So think of BCPs use EMR, except the E is an A here. So it sounds the same, right? AMR, EMR. So PCP, AMR. Next we have psychiatric emergencies. So first we have psychiatric emergencies. Serotonin syndrome. What causes serotonin syndrome is any drug that increases serotonin, also known as 5-HT. Psychiatric drugs like MAO inhibitors, SSRIs, SNRIs, and TCAs, vilazodone, vortioxetine, and bisphorone all increase serotonin in the body. They're all drugs that increase serotonin in the body, causing serotonin syndrome. The non-psychiatric drugs that increase serotonin will be tramadol, ondansetron, triptans, linezolid, MDMA, and dextromethorphan, and meperidine and St. John's wort. Manifestations of serotonin syndrome would be neuromuscular, like clonus, hyperreflexia, hypertonia, tremor, and seizure. You would see autonomic instability, like hypothermia, diaphoresis, diarrhea, and altered mental status. Treatment is cyproheptadine, which is a 5-HT2 receptor antagonist. So it's a serotonin antagonist. Okay. So what you have to know is clonus is involuntary, sustained rhythmic beating movement of the ankle once you dorsiflex the patient's foot. So the ankle, like the entire foot, will keep dorsiflexing once you dorsiflex the patient's foot. It will just keep going, and that's clonus. Okay, you can look it up on YouTube. And also, serotonin syndrome will present with hyperreflexia. This is when the muscles have overactive response to hitting it with the knee hammer, hitting the knee with a knee hammer, elbow. When you hit the elbow, reflexes. So the muscles have overactive response. The normal reflex is 2 plus. Hyperreflexia would be 3 plus or 4 plus. And you also see hypertonia in serotonin syndrome, which is when the muscles are too rigid. Um, you can't flex the muscles, so there's decreased flexibility. Tremor. You also see tremor in serotonin syndrome. You have a seizure. Um, the autonomic instability is hyperthermia, diaphoresis, which is when you're excessively sweating, and diarrhea, and also ultramental status. Okay, next we have hypertensive crisis. Hypertensive crisis is eating is caused by eating tyramine-rich foods like aged cheese, cured meats, wine, chocolate, while you're also taking MAO inhibitors. Manifestation is hypertensive crisis because tyramine replaces other neurotransmitters like norepinephrine and causes increase in BP. And this happens. The neurotransmitter getting replaced happens in the synaptic cleft, and this leads to increased sympathetic stimulation, which is why you have hypertensive crisis. The treatment is phentolamine. Neuroleptic malignant syndrome, also known as NMS. Um, NMS is caused by antipsychotics. Typical antipsychotics have greater risk of causing um, NMS than atypical. Typical is first generation antipsychotics, and atypical is second generation antipsychotics. Um, NMS also has a genetic predisposition to developing NMS once a patient is given antipsychotics. Uh, the mnemonic is fever. In NMS, you have myoglobinuria, which is red urine. You have fever, encephalopathy, vitals are unstable. There is increased enzymes like CK is increased. So this creatine kinase would be increased as the CK is found in the skeletal and heart muscles. So in NMS, you're breaking down. I don't know if it's breaking down muscles, but I guess it's because of the. I mean, how else would you have CK if your muscles aren't breaking down? Hmm. Because it's in your muscles. CK is in your muscles. It's a marker of muscle damage. So it says the antipsychotics can cause muscle damage, leading to release of CK into the bloodstream. Oh, okay, that's what it is. I guess you are breaking down muscles. So the antipsychotics causes muscle damage. Think of it as breaking the muscles, and then the CK is released into the blood, causing high CK. You also have muscle rigidity and lead pipe muscle rigidity. Lead pipe muscle rigidity is a type of muscle rigidity characterized by a smooth, constant resistance to movement throughout the entire range of motion. So you can look it up on YouTube, but it's stiffness on passive limb movement. The body is bent forward. So lead pipe rigidity is a constant resistance to motion throughout the entire range of movement. So in NMS, you have lead pipe rigidity, which is resistance against you when you try to bend the patient's arm back. You have unstable vitals in NMS, which is increased heart rate, increased respiratory rate, and your BP can fluctuate between high and low. Myoglobinuria is from muscle necrosis. So that muscle gets necrosed, and the myoglobin leaks out of the muscle into the urine, causing myoglobinuria, which is a red urine. Um, yeah, and these are all the signs and symptoms of NMS, or neuroleptic malignant syndrome. The treatment is by dantrolene, dopamine agonists like bromocriptine, and you had to discontinue the antipsychotic, which is most likely it's going to be a typical or first generation antipsychotic. That's what usually causes the NMS. So you give dantrolene or bromocriptine, um, and you have to discontinue the first generation antipsychotic. And NMS is a psychiatric emergency. I mean, they all are, but I've seen NMS in real life, and I know how. Um, I'll never forget the symptoms of NMS. Okay, delirium tremens. Delirium tremens is caused by alcohol withdrawal, occurs 2 to 4 days after the patient's last drink. Delirium tremens is classically present in hospital setting when inpatient cannot drink. Yeah, classically seen in a hospital setting when inpatient cannot drink. So, yeah, it's seen in patients who have been admitted to the inpatient setting, like ICU, CCU. Obviously, they can't drink in the hospital, and that's when you go into alcohol withdrawal. And somebody who's alcoholic goes into alcohol withdrawal, and then you get symptoms um, in 2 to 4 days. Um, so the symptoms are altered mental status, hallucinations, autonomic hyperactivity, um, which would be increased heart rate, increased respiratory rate, mm, high BP, and then you also have anxiety, seizures, tremors, psychomotor agitation, which is very fidgety. So the patient will be very fidgety. Um, you can also see insomnia and nausea in somebody with delirium tremens. The treatment is by benzodiazepines, like chlorodiazepoxide and lorazepam and diazepam. You avoid Benadryl and drugs that increase the parasympathetic activity in somebody that has delirium tremens. Now, next, acute dystonia. Acute dystonia is caused by typical antipsychotics. Yeah, acute dystonia is caused by typical antipsychotics and anticonvulsants like carbamazepine and metoclopramide. The symptoms would be sudden onset of muscle spasms, stiffness, and/or oculogeric crisis occurring hours to days after the medication use. Acute dystonia can lead to laryngospasm requiring intubation. The treatment is by benzodiazepine or diphenhydramine. Okay. Oculogeric crisis. Let's look it up. Okay. So let's see. So it's when your eyes are in upward, they're stuck in an upward position due to antipsychotic use. It's a side effect of antipsychotics. So your eyes are stuck in the superior position. Okay. Laryngospasm. Laryngo. So that's when your um, vocal cords contract. Okay, so these are your vocal cords. Um, this is normal vocal cords, and this is closed vocal cords. So this is what happens when you take antipsychotics. It's a side effect of antipsychotics, and this causes breathing obstruction and requires intubation. Yeah, the vocal cords, um, they during breathing they open to allow air to flow in and out of the lungs. So besides sound production, the vocal cords they help in swallowing and breathing. During swallowing, the vocal cords close to prevent food or liquid from entering the trachea. During breathing, the vocal cords open to allow air to flow in and out of the lungs. So, antipsychotics can snap the vocal cord shut, which would always not allow you to eat, and you also can't breathe. Okay, so quick anatomy lesson. Here we have the epiglottis, supraglottis, glottis, um, and subglottis. And this entire thing collectively is known as the larynx. Next, right here underneath the larynx we have the trachea, and behind the trachea we have the esophagus. So, what happens in acute dystonia is that the larynx it it stops. I mean, stops, contracts, so it closes, and so when you breathe, the air cannot pass through into the trachea. So, so then you need to be intubated. You need to be mechanically intubated for this. Um, so normally during swallowing, the larynx moves upwards and closes to prevent food or liquid from entering the trachea. So the larynx closes to prevent food or liquid from entering the trachea, and the epiglottis covers the opening of the larynx, directing the food or liquid to go into the esophagus. Okay, so this is like they all work together. So epiglottis covers the larynx, and when this is closed, the food moves into the esophagus. And then during swallowing, the larynx moves upward and closes to prevent the food or liquid from entering the trachea. Okay, so that's like the normal function. But in acute dystonia, due to the use of antipsychotics, um, you can contract. The larynx can contract, and the air cannot pass into the trachea. So, the patient needs to be mechanically ventilated because they can't breathe. Okay, next. Yeah, we said you give benzodiazepine or diphenhydramine in acute dystonia, and this is the condition where eyes are stuck in upward gaze, also known as oculogyrate crisis. Next, we have lithium toxicity. Now, lithium toxicity is something they really like to ask you about because it ties in with renal. Um, there is an increase. The cause of lithium toxicity is if you have increased lithium dosage and decreased renal elimination due to causes like acute kidney injury, or if you take medications affecting clearance, like ACE inhibitors, thiazide and NSAIDs. Lithium toxicity has a narrow therapeutic window, which means it only takes a little bit of medicine to go into the toxic stage, right? So lithium has to be monitored. The signs and symptoms of lithium toxicity would be nausea, vomiting, slurred speech, hyperreflexia, seizures, ataxia, nephrogenic diabetes insipidus. The treatment is to discontinue lithium, hydrate aggressively with isotonic sodium chloride, consider hemodialysis. Okay, so a few things to note here. Increased lithium would cause increased lithium buildup in the blood, and decreased kidney excretion would also increase lithium in the blood. Okay. Now, ACE inhibitors can decrease renal clearance. So, a patient on both ACE inhibitors and lithium, the kidney cannot clear lithium easily. So that's why ACE inhibitors would decrease the amount of lithium being cleared out of the kidney. NSAIDs. NSAIDs are important to know too. So renal blood flow and GFR. Renal blood flow and GFR both decrease when somebody is normally on NSAIDs, right? So NSAIDs constrict the afferent arteriole naturally. So this would decrease the renal plasma flow and decrease the GFR. So if GFR is decreased and somebody is on lithium and NSAIDs, that would decrease the amount of lithium that can be excreted. Okay, next. Now we have the signs of lithium toxicity. Lithium toxicity can cause nephrogenic diabetes insipidus, which is when ADH doesn't work, so there will be increased urine volume. ADH does not work, so there will be increased urine volume. You're peeing out all your water. This would cause a dehydration in the patient. Okay. All right. So treatment options to discontinue lithium: hydrate aggressively with isotonic sodium chloride. Consider hemodialysis. Okay. Next, we have TCAs, tricyclic antidepressant toxicity. The reason is because you take too much TCAs. Signs and symptoms: respiratory depression, hyperpyrexia, prolonged QT. You also see convulsions, coma, cardiotoxicity, and arrhythmia is due to the sodium channel inhibition. The treatment is supportive. Monitor ECG. Give sodium bicarbonate because sodium bicarbonate prevents arrhythmia. You can also give activated charcoal for TCA overdose. Okay, so let's see QT interval. So this is normal QT interval from right here, this blue shaded region, to here. Now this is normal QT, but in TCA overdose you see prolonged QT. Okay, right here. Okay, so remember this. Be familiar with this chart. This ECG. Okay, all right.